Yeah. So what are we going to do today? The first part of the class, I want to do the introduction to ECG, right? So this is a usual formal class I have been doing because you are aware when it comes to this Viva session 2, we are having a full-blown ECG class. Before going into the ECG class, I want to make the basics clear, right? Okay. So the very basics of ECG, the initial basics of ECG, or whatever you have to do before starting a proper ECG class, I will do in the first part of the class. Okay. The second part of the class will be part of our right. We'll be doing an ECG emergency. It's a common case scenario which everybody should know in and out. Clear? A common case scenario which everybody should know in and out. Clear? There will be a lot of ECGs, right? There will be a lot of ECGs in the second scenario, right? Those who are just introduced to the ECG today may be a little bit difficult, doesn't matter, right? After the ECG full class, it will be okay. Understood, guys? Right? Okay. So that's the thing, right? Okay. So this integrated word class we have introduced from the last year once this online system was put into place, right? I think last year I have done about 3 or 4, right? One is this, I have done one on stroke, and I think I have done one on 2 classes on a walk through diabetes, right? I told you right yesterday, I have just something on the brain is on fire, right? And I just want to do something on Parkinson's as well, right? Am I getting slow, right? The topic will be, am I getting slow? So these are in addition to whatever we are routinely doing in the classes, right? Okay. So this is to give you some additional knowledge. Okay, guys, that's it. Okay. Shall we start? Make sure the cameras are on. If the cameras are not on, you will be removed from the meeting. You can't join again. It's not waiting room. You will be removed. Clear? So with that introduction, we'll start off the topic, right? We'll start off the first part of the class, right? Okay. Okay. Fine. Right. The series says is ECG made easy 1, right? Because as I said, right, this is the introduction to the ECG, right? The very basics of ECG. Make sure your mics are muted, eh? Right? Okay. Look here. Point number 1, guys, look here. The ECG is one of the hot topics or one of the areas, right? One of the areas, right, where the students struggle, or the moment they see an ECG, sometimes they panic, right? The topic says ECG made easy. My first point before starting this topic is that topic is a misnomer, right? Topic is a misnomer, right? So you don't have to make ECG easy because it's already easy, right? It's already easy. Provided you understand the basics, right, it won't be a big issue. If you don't know how to mute it, can't help it. I'll remove the people, right? Because I don't have time for this nonsense, right? Okay, right. Look here. So the topic is a misnomer. ECG is already easy. So ECG made easy is just a misnomer, right? The second thing, right? So what we are trying to do with the ECG is, right? What we are trying to do with the ECG is, right? Give me a second. We are trying to, as you're all aware, we are trying to record the electrical activity of the heart, right? So what you do is you put something in your chest, right? You put some leads in your chest, right? You put some leads in your chest. By putting these leads, you are trying to look at the electrical activity of the heart. So before understanding the electrical activity of the heart, we should have some idea about the blood supply of the heart, because majority of the time, right, we talk about ECG in relation to the blood supply of the heart. So if you look at the blood supply of the heart, I hope you remember, right, we are aware the heart is supplied by 2 coronary arteries. Yes or no? The heart is supplied by 2 coronary arteries. So if you look at the heart, guys, look here. If you look at the heart, right, so from the aorta, right, from the aorta, there are 2 coronary arteries which are coming. What are 2 coronary arteries? Just, yeah, come on, guys, start.
Right coronary artery and left main
Left
coronary.
and the right. It is the left and the right. It is the left and the right. Right. It is the left and the right. Okay. It is the left and the right. So if you look at these 2 coronary arteries, they are emerging from the aorta. They are emerging from the aorta. Right. At the origin of the aorta, there are some cusps, guys. Like there are 3 cusps there at the origin of the aorta. So if you look at the left coronary artery, it is starting at the origin of the aorta. It is starting somewhere here. It is starting somewhere here. So at the origin of the aorta, it is starting from a cusp called left posterior aortic sinus. Right? It starts from the left posterior aortic sinus. Right? Left posterior aortic sinus. If you look at the right coronary artery, it is starting from the anterior aortic sinus. Okay? Anterior aortic sinus. So if you look at these arteries, guys, right? If you look at these arteries, right? So your left coronary artery in the initial part, you may remember the good old days in cardiology or you studied in the theory. The initial part is called left main coronary artery. Right? The initial part is called left main coronary artery. So this is the one in the short form. We are calling this as the LMCA. Right? This is the one in the short form. We are calling this as the LMCA. This is how it starts. Because this is very important to know, because, right, in another fine day, we'll study, like, if you have an obstruction here, that the origin, right, at the origin, right, we'll study there are some particular ECG changes which we should not miss, right? So there are some particular ECG changes, we should not miss that, right? Like it's something, that's an absolute origin. So once it has started, guys, look here, right? It gives a branch here. Everything is here in the tube or the slides, right? It gives the branch here, which is called the left circumflex, right? It is called the left circumflex artery, right? It is called the left circumflex artery. So after giving the left circumflex artery, it is running anteriorly, right? It is running anteriorly. So you may be aware, right? You may be aware, right? This is your right ventricle. This is your left ventricle. It is actually running in between the ventricles, right? It actually running in between the ventricle. That's why the anatomical name for this part is, right? Anatomical name is anterior interventricular artery, right? Anatomical name is what? Anterior interventricular artery, right? So even though this is called anterior interventricular artery by the anatomical terms, right? By the anatomical terms. So in medicine, right, in cardiology, we love to call these as LAD, right? LAD, L-A-D, LAD. Clear? We love to call this as LAD. That is the term we use in cardiology, right? What is LAD? Right? What is LAD? That is the left anterior descending, right? That is the left anterior descending, right? Left anterior descending, right? Left anterior descending artery, right? LAD, left anterior, right? Descending artery, right? Descending artery, left anterior descending artery, right? Okay, right? So that's how the anatomy of the left coronary artery, just so you can see here, this is the left coronary artery starting as the left main coronary artery. This is the main trunk. So it gives a branch here, circumflex, and then it comes anteriorly as the anterior interventricular artery. So when you see here, guys, look at me, look at me, look at me. Right? It's very important to understand from here itself, right? So just look at the left circumflex, right? Just look at the left circumflex. So this is lateral side of the heart, yes or no? Right? This is the lateral side of the heart, right? This is the lateral side of the heart. This is the lateral side of the heart, right? This is the lateral side of the heart. So if you look at the left circumflex, so it is mainly supplying the lateral side of the heart, isn't it? It is mainly supplying the lateral surface of the heart. It also supplies this left atrium. You can see, right? Right? This part of the left atrium, this part of the left ventricle, and it supplies this lateral surface of the heart. Yes or no? So why this is important? Tomorrow, if you have a block here, right? If you have a block here, these are the parts of the heart which is going to undergo ischemia, right? So that's what we are going to correlate in ECG. We are going to say the changes are there in the leads which are looking at this part of the heart. Understood? Yes or no? Right? So coming here, guys, look here. Coming here, coming here. So this is your anterior interventricular artery. So it supplies, you can see here, it supplies part of the left ventricle. So this portion of the right ventricle, and you can imagine what is inside is the interventricular septum, right? What is inside? It is the interventricular septum. So it supplies the left ventricle. You can see here, it supplies this area. This is your left ventricle, right? This is your left ventricle, right? Okay, right? Don't write anything here, right? This supplies this part. This is your right ventricle, right? So inside the heart, you are having the interventricular septum. Actually, within a few minutes, we are going to discuss. This is actually supplying the anterior 2/3 of the septum, right? This is actually supplying the anterior 2/3 of the septum, right? Anterior 2/3 of the septum, right? Okay, guys. Right, look here. Now the next point, look here. Right, that is clear now. So if you look at the right coronary artery, guys, look here. So again, it starts from the aorta. It comes like this. It comes like this. So when it comes like this, here it is giving a branch. This is called marginal artery. Right, this is called what? It's marginal artery. It is called marginal artery. Right? It is called marginal artery. So, right. So after giving this branch, it runs on the back of the heart, inferior surface of the heart. It curls down. It curls down. It runs on the inferior surface of the heart, and in the inferior surface of the posterior side of the heart, it is giving a branch called posterior interventricular artery. Like posterior what? Interventricular artery. Like posterior interventricular artery. So if I show you in this photo, right? So you can see here, this is your right coronary. This is your right coronary, right? So this is your right coronary, right? This is your right coronary. It started from the anterior aortic sinus, right? So it goes, it comes here, it comes here, it comes here. It gives you the marginal branch, right? It gives you the marginal branch, and it curls back and gives the posterior interventricular artery, right? Okay, right? Understood? Right, look here. So you can understand from here. So if you have a problem with the right coronary artery, this right side of the heart, say right atrium, right ventricle, and the inferior surface of the heart, these are the parts which are going to undergo ischemia. Right, just going to undergo ischemia. That's clear now, right? So if this is important to know the blood supply of the heart, right? Is this important to know the blood supply of the heart? If you are a first year medical student, it's very important to know the blood supply of the heart, because this can be asked in the anatomy viva, right? Or in the anatomy exam. This may be a question in the anatomy exam, right? So this is something you have to know for the rest of the life, because not just because of the anatomy, right? If you don't know these basics, right, you will never understand the ECG, right? You will never understand the ECG. And Lamai, look at me. So, well, so there are two coronary arteries, isn't it? Right and left, right and left. Even though two coronary arteries, only right and left. So if you talk about the clinical significance, I will tell you, clinically, there are three significant vessels here. What are the three significant vessels clinically? One is the left anterior descending artery. right, left anterior descending artery. Second is your circumflex artery. Third is your right coronary artery. Right, third is your right coronary artery. So in clinical point of view, we are talking about 3 significant vessels. That's why you might have heard the term called, right, say a patient with an ischemic heart disease. We are telling sometimes, okay, this man is having a triple vessel disease, right? Right, you might have heard a term called, right, this person is having a triple vessel disease, right? From where does the third vessel come, right? So where does the third vessel come? Because clinically we talk in terms of 3 vessels. Is that is clear? Right? Yes, no, we don't know. Right? Understood, guys? Somebody unmute and say. Come on.
Yes, sir.
Yeah, okay, fine, good. Right, look here, guys. Right, now look here. Right. So why this is important in the real life? Right, why this is important in the real life? Right? Tomorrow, if somebody gives you, like, this is my angiogram, doctor, right? Okay, this is my angiogram, doctor. Can you have a look and tell me? At least we should know what is there. Right, okay, okay. We should not go blank, no. Right, look here, guys. So this is the angiogram, guys. You can see, right? So this is your left main coronary artery. So you can see here, it gives the left circumflex artery. It gives the left circumflex artery, and it comes here as the left anterior descending artery. So when I see that, I know, okay, right, this is the right cardiac vessels, and this is the anatomy. So here I can see the right coronary artery also, right coronary artery also. I can see the right coronary artery. I can't see this part very clearly, but I can see the initial part of this. Right? Yes or no, guys? Right? Okay. I'll show you one more image here. Right? So here, look here. We are actually, what we have done here, this is your catheter. Right? This is your wire, right? Catheter. So you take the catheter and you have injected the dye into the left main coronary artery. Right? You have injected the dye into the left main coronary artery. So can you see this, right? So when you have injected the dye into the left main coronary artery, so you can see nicely here, right? So you can see nicely here, left main coronary artery, because if there is a block here, I'm worried, right? If there is a block here, I'm worried, right? So left main coronary artery block is one of the places, right? Instead of sending, sometimes we'll go to the surgery directly. You will refer the patient to the cardiothoracic surgeon to go ahead with the CABG bypass. Right, so you can see here, guys, look here. So this is a left main coronary artery, and I can see the circumflex nicely going there. I can see the circumflex nicely going there. So I can see this left anterior descending artery. But you can look at the vessel, guys. Look at the thickness of the vessel here, and look at the narrowing here. Right, so we can see roughly about 50% narrowing, or 50 to 60% narrowing somewhere here. Right, yes or no? Right, you can obviously see the look at the thickness of the vessel here. Look at the thickness here, right? So this is the reason, right? This is the reason we are studying this blood supply of the heart, right? Understood? Right? Right. So I know they are not going to give this in the exam. Nobody is going to ask you to interpret an angiogram in the exam. But without knowing this basis, you can't be a successful fellow in the field, right? Okay. Now look here. So majority of the time, guys, I told you, right? So this posterior interventricular artery, right? Posterior interventricular artery, as I have shown here in the blackboard, right? As I have shown here in the blackboard, this posterior interventricular artery starts from the right coronary artery. In other words, 90% of the time, this is the right coronary artery which is giving this posterior interventricular artery. So those people, right, majority of the time, that's the scenario. So those people we are saying right dominant, right? Those people we are saying what? Right dominant, right? In other words, the artery in anatomical terms, the artery which is giving the posterior interventricular artery is supposed to be the dominant artery, right? Understood? Right? I mean, if you are first year or second year, this is a question in the anatomy exam, right? So, okay. So this is what we have discussed. The heart is getting the blood from these two arteries, right? We have discussed about that. So, coming back to this, right? So the area supplied by the individual vessels, right? So left anterior descending artery, it is supplying the right ventricle, left ventricle, and the interventricular septum, right? So you can see here, it supplies a part of the left ventricle, it supplies a part of the right ventricle, and it actually supplies the anterior 2/3 of the interventricular septum. Right, it's MCQ point. It's MCQ point in the first year, it's MCQ point in the ERPM. Right? If you look at the last time, not this time paper, the paper before it was MCQ. Right, the same statement was there. Right, anterior 2/3 of the septum was supplied by the left anterior descending. So if you look at the circumflex artery, right, if you look at the circumflex artery, so it supplies the left ventricle, right, anterior, lateral, and the posterior aspect, as well as the left atrium, right, as well as the left atrium. Obviously, right now, so it supplies this left atrium here, right, it supplies the anterior, lateral, and some posterior aspect of the left ventricle, right, understood? It's straightforward, right? Right. So if you look at the right coronary artery, so it supplies the right atrium, it supplies the right atrium, right, look here guys, right? So this is your right atrium, it supplies the right atrium. The very important point, that's the clinical significance, and today after this, the second part of the class, right, we are going to discuss in the discussion the next, case scenario also. So remember this point, this right coronary artery is the one which is supplying the, right, your conduction system of the heart, right? So you may remember this conduction system of the heart, right, your SA node and AB node, right, SA node and AB node, right, this right coronary artery is supplying the conduction system of the heart. Clear? So why this is important? So when the problem is there in the right coronary artery, right, what else will be affected? Your conduction system will be affected. Right, conduction system will be affected. So that's why we are studying when there is a right coronary artery occlusion, you can develop heart block. Clear? Okay. Right, you can develop heart block. Fine, look here. So, right. Fine. So right marginal branch supplies the right atrium and the right ventricle, and the posterior descending artery, it supplies the right ventricle, left ventricle, posterior aspects, and the posterior 1/3 of the interventricular septum. Right, right. Okay. So that's clear now. Right. Now look here, guys. Now, what are you going to do in the ECG? Right? What are you going to do in the ECG? Right? What are you going to do in the ECG? All of you might have seen this ECG, might have heard about this ECG. So what do you do in the ECG is, look at me, right? What do you do in the ECG is, we are trying to look at the electrical activity of the heart, right? We are trying to look at the electrical activity of the heart. So how are you trying to look at the electrical activity of the heart? You are placing some leads in the front, right? You are placing some leads in the surface, and by putting these leads in the surface, you look at the electrical activity of the heart. Clear? The same thing you will do in the brain, right? Right? You don't have to know about that, right? So the same thing when you do in the brain, you will call that as EEG, right? So what you do in the brain is you are going to do the same thing, right? So where you are trying to, monitor the electrical activity of the brain by putting some leads in the scalp, you call that as EEG. Right here we call this ECG, electrocardiogram. Right, look here, guys. Now, how many leads are there in the ECG? Yeah? Come on. Yeah?
12.
In a routine ECG, normal ECG, how many leads are there?
12.
12. Okay, very good. Right, in a normal ECG, right, in a normal ECG, as you rightly said, look here. Right, in a normal ECG, as you rightly said, there are 12 leads. Don't write, listen. Right, there are 12 leads. There are 12 leads. So you may remember, if you look at the normal ECG, right, if you look at the normal ECG, say it's an ECG, right, okay, it's an ECG, right. So these are the 12 leads, right, look here, guys, look here. So here is something called V1. Here is something called V2. Right. Here is something called V3. Here is something called V4. Here is something called V5. Here is something called V6. Right. So this is V1. This is V2. This is V3. This is V4. This is V5, V6. Right. This is V5, V6. So listen to me. Right. So if you look at the normal ECG, right, there are 12 leads. Look here. There are 12 leads. So this V1, V2, V3, V4, V5, V6, right? This V1, V2, V3, V4, V5, V6. We call these 12 leads. Out of the 12 leads, these V1 to V6 are the 6 chest leads. Come on, look here. Right, chest leads. Right, don't write. Just listen. Right, these are the 6 chest leads. These are the 6 chest leads. Chest leads. Right. These are the 6 chest leads. These are the 6 chest leads. Understood? Look here, guys. Look here. Look here. In addition to that, right? In addition to that, right? Right here we are having another tree called. Look here. Look here. Look at the ECG paper. Right? Look at the ECG paper. Here you are having something called AVR. Right? Here you are having something called what? AVR. Right? These are 6 chest leads. Right? Right? Here you have something called AVR. Here you have something called AVL. Here you are having something called AVF, isn't it? Right, AVR, you can see like AVR, like this is your AVR, this is your AVL, this is your AVF. So we have seen here this V1, right, V2, V3, V4, V5, V6, right, V1 to V6, there are 6 chest leads, and here we are having what? AVR, AVL, AVF, right? So this is the 6 chest leads. So in addition to this, now we are having another tree called what? AVR, AVL, AVF, 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 AVF. Understood? Right now, the next point. So if you look here, right, there is another 3 leads here, right? There is another 3 leads here. This is lead 1, lead 2, lead 3. 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 Right, lead 1, lead 2, lead 3. Right, lead 1, lead 2, lead 3. Lead 1, lead 2, lead 3. Right. So look here, guys. Right. So V1 to V6, AVR, AVL, AVF, and lead 1, lead 2, lead 3. Understood? Right, understood. So what are your 12 leads? Tell again one more time. Huh? Tell.
Chest leads, limb leads.
Yeah, there are
A1, A2,
6
A3.
chest leads, V1 to V6. Right.
3 limb leads.
Right, 6 chest leads, V1 to V6. Right. So there is AVR, AVL, AVF, and lead 1, lead 2, lead 3. Lama, listen to me. Listen to me. Right. The message I want to tell you, my first message I want to tell you, listen to me carefully. So this is your ECG. Now you are seeing 12 leads. Yes or no? You are seeing 12 leads. Like most of you or majority of you, you might have seen this ECG when they are taking the ECG. Yes or no? Right? When they are taking the ECG, you might have seen the procedure, right? They are putting something in the chest, isn't it? They are putting something in the chest, right? They are putting something in the hands and legs, right? They are putting something in the hands and legs, right? Right, look here, guys. So you have seen this, right? The pasting of these, right? Yes or no? Right? Yes, in. Lamai, look at me. So what do you paste? What do you paste? Lamai, look here. What do you paste? Right? Now, what do you paste is, guys, right? The metal you are pasting is called electrode, right? The wires you are pasting, Lamai, listen to me, right? The wire you are pasting is called electrode, right? Electrode. So where do you put the electrode? Say this is V1, V2, V3, V4, V5, V6. You are putting 6 electrodes in the chest, right? We are putting what? 6 electrodes in the chest. We are putting 6 electrodes in the chest, right? So now in 4 limbs, right? In the right arm, left arm, right lower limb, left lower limb, we are putting 4 electrodes in the limbs, right? We are putting 6 electrodes in the chest. We are putting 4 electrodes in the limbs. We are putting 4 electrodes in the limbs, right? So all together, how many electrodes we are putting?
10.
10 remember, yes, good. All together, we are putting 10 electrodes, right? All together, we are putting how many electrodes? 10 electrodes. All together, we are putting 10 electrodes, right? All together, we are putting 10 electrodes, right? Okay, 10 electrodes. Understood, guys? Right, 10 electrodes. So my message to you at this point is, look at me. The word lead is different. The word electrode is different, right? The word lead is different. The word electrode is different. So by putting 10 wires, right? By putting 10 wires, by putting 10 electrodes, we are getting an outcome. What is the outcome to a lead ECG? You got it, guys? Right? The word electrode is different. The word lead is different. By putting 10 electrodes, what you get as an outcome is that to a lead ECG. Right? Right? Okay. So how the 10 electrodes bring the 12 lead ECG? Right? How the 10 electrodes bring the 12 lead ECG? There comes the physics. Right? Right? Okay. So the electrical activity of the heart is something like a, like if you tell in terms of physics, it's a force. F, force. Right? You might have learned good old days in the physics class, advanced level. Maybe the kids may be aware better. Right? So these forces, they are vectors. Right? Vector. You heard the vector word vector. Yes, those are vectors. Right? Okay. Understood. Right. So by putting 10 electrodes, the number of electrodes we are putting is 10. The outcome we get in the paper is 12. Right. By putting 10 electrodes, we are getting the 12 ECG. Right. This is the normal ECG. Right. I'll come to the additional points from now onwards. Right. That point onwards. Look here. Now, how do you put these leads, guys? How do you put these lights? So just have some idea. Right? Say, just have some idea, right? How do you put these leads, right? Okay, right? You have seen these photos, right? You have seen the technician doing this, right? Your ECG technician will come and paste this. So where does he, right? Okay, where do you put that is, where do you put this is, okay, where do you put this is, right? The V1 is put in there, right intercostal space, right fourth intercostal space, just lateral to the sternum. Right fourth intercostal space, just lateral to the sternum. Right? Okay. V2 is placed in there, fourth intercostal space on the left side of the sternum. Right, left side of the sternum. Right, look at me, guys. Right, look at me. Right, what is this? What is this notch? Doing yourself, what is this notch?
Sternal notch.
Sternal notch. This is a sternal notch. So when you come down from the sternal notch, you will see an angle. When you come down from the sternal notch, you will see an angle. What is that angle?
Sternal angle.
Sternal angle. So what is the intercostal space immediately lateral to the sternal angle?
Second intercostal.
Second. So it's not a problem, no. Third, fourth, we can count. Right, second, third, fourth, you can count. Right, second, third, fourth, you can count. So you count there and you put on the right side, just lateral to the sternum, V1. You put on the left side, just lateral to the sternum, you put the V2. Understood? So where do you put the V4 is, right? Where do you put the V4? This is your V4. Right? It is put in the mid-clavicular line in the fifth intercostal space. Right? The mid-clavicular line, you know this is a clavicle, you know this is a mid-clavicular line. In the mid-clavicular line, right? In the fifth intercostal space, you put the V4. Right? So once you put the V2 and V4, in the midway between the V2 and midpoint, between the V2 and V4, you put the V3. You put the V3. Right? You put the V3. Understood? Right? Right? Okay, the midpoint, you will put the V3. So where do you put the V5 is? V5 is the same fifth intercostal space in the anterior axillary line, you put the V5, right? The same intercostal space in the mid axillary line, you put the V6. And the next 4 are put in the limbs, no, so it's not a problem. Understood? Right, look here, guys. Now, right, other 4 you put in the limbs, right arm, left arm, right leg, left arm. So nobody is going to ask you, how do you put the leads? Right, it will be never checked in the exam. Nobody is going to ask this, right? But having said that, if you know this is an advantage, right? If you know this is an advantage, right? Okay, right? Why is that? When I tell a simple story, right? When I was a house officer, right, I was doing medicine, like I was reading medicine, and we had one of the best practitioners, like I was with the best consultants at NHS at that time, right? So, right, is it there now? Right, so we are doing medicine, and right, 2 days, ECG technicians went on strike. Right, ECG technician went on strike. Right, so what you know is the right patient is coming with the chest pain. Right, patient is coming with the chest pain. Right, acute chest pain, as you all say, is acute coronary syndrome until proven otherwise. Right, acute chest pain is acute coronary syndrome until proven otherwise. We don't know the rest. Right, whether it's a ST elevation MI, right, whether this is a non-ST elevation MI, whether this is an unstable angina, whether this is a left bundle branch block new onset, we don't know, right? So all the rest of the wards, they were just giving enoxaparin, right? They were just giving enoxaparin. So what we did in our ward was, like, we asked the technician on strike, no, doesn't matter. We got down the machine, right? We got down the machine to our ward, right? And we chose, right? We did the ECG and managed according to the ECG. Clear, right? Understood? So in a way, it's good to know, right? Because if you're good to know, right? I always tell my students, and even before, when you are starting the internship also, I have a seminar with you, there we discuss, right? It's good to know the attendant work, right? It's good to know the nurse work. It's good to know the technician work, because nobody can cheat you then, right? Nobody can cheat you. So you know what is done, right? Right? But you should not do that every time. You should not do that every time, because otherwise you have to do it forever, right? But you should be able to do in an emergency, right? Right, wait, right, okay, that's about that, right? Right, okay, guys. The next point, right? Right. Look here, guys, right? Come on. So, right, before coming to this, right? Right, these are leads, no, right? Right. Look at me, guys. I'll come to this point first. So just imagine the heart as the 3D structure. Heart as the 3D structure. Right, heart as the 3D structure. Right, I hope you are no, right, you are there, right? The heart is normal like that. Right, it's a 3D structure. Right. So if you look at the heart, come on, listen to me. So these are the leads we have put, no? These are the leads we put. So if you look at this V1, V2, look at me, look at me, look at me, look at me. If you look at this V1, V2, they are mainly looking at the septum of the heart. They are mainly looking at what? The septum of the heart, as well as the anterior surface also. They are mainly looking at the septum of the heart, as well as the anterior surface as well. They are mainly looking at the septum of the heart, as well as the anterior surface as well. So if you look at these leads, right, you can imagine here, right, it's like this, no? Right, so your heart is somewhere like this, no? Right, so if you look at these leads, they look at your heart like this. They look at your heart like this. They are mainly looking at the V3, V4, right, V3, V4, right? Say, look here, guys, look here, look here, look here, look here. This V3, V4, look here, look here, look here. Right, this V3, V4, they mainly look at the anterior surface of the heart. Right, this V3, V4 mainly look at what? Anterior surface of the heart. They mainly look at the anterior surface of the heart. Right, look at me. Right, okay, you just stick to my words. Don't worry about too much. Right, look here. So if you look at this V5, V6, right, so we'll go back to the previous image also. Like if you look at this V5, say, look at me, this V5, V6, they look at what part of the heart? They look at the what part of the heart? Lateral side of the heart. This V5, V6, they look at the lateral side of the heart. They look at the lateral side of the heart. They look at the lateral side of the heart. Look at me, guys. Look here. Now we are talking about the chest leads. We have said this V1, V2 is looking at the anterior surface of the heart. We said this and the septum of the heart. This V1, V2 is looking at the septum of the heart and the anterior surface of the heart. Right? So that is obvious here, no? Right? That is obvious here. Right? It looks like this. It looks at your heart like this. Right? It looks at your heart like this. It looks at your heart like this. Right? So this V3, V4, it look at your heart like this. It look at your heart like this. Right? It look at the anterior surface of the heart. This V5, V6, right? This V3, V4 looks here, looks here, looks here, looks here. Right? This V5, V6, right? This V5, V6, right? This V5, V6, right? This V5, V6, they look at the lateral side of the heart. Right? This V5, V6, they look at the lateral side of the heart. Clear? Okay. Are you there? Yes, no, we don't know. Right? Now look here, guys. So, in addition to these, what are the other leads, guys? Tell. V1 to VC, now I discuss. What are the other leads? I mean, I got in the blackboard.
AVR,
AVF. Lead 1, 2, 3. Am I right? AVR, AVL, AVF. What is left now? Lead 1, 2, 3. Am I right? Come on, look at me. Look here. If you look at the AVL, right, this is your AVL. This is your AVL. This is your AVL. This is your lead 1. So if you look at the AVL and lead 1 here, they also look at the lateral side of the heart. If you look at the AVL and lead 1, they also look at the lateral side of the heart. Right? If you look at the AVL and lead 1, they also look at the lateral side of the heart. Right? Now, so far, what are the leads looking at the lateral side of the heart?
V5,
V6,
V5, V6,
AVL and L1.
AVL and L1. V5, V6, AVL and L1. Understood? V5, V6, AVL and L1. Look here, guys. They look at the lateral side of the heart. Look here. So if you look at these 3 leads, guys, look at me. Lead 2. Look here, the lead 2. This is your lead 2. This is your lead 2, lead 2, lead 2. This is your lead 3. Right? This is your lead 2. This is your lead 3. This is your AVF. Right? This is your lead 2. This is your lead 3. This is your AVF. So if you look at the lead 2, lead 3 AVF, look here, guys. They are looking from the bottom, isn't it? They are looking from the bottom. They are looking from the bottom. So they look at the inferior surface of the heart. Right? They look at the inferior surface of the heart. Right? They look at the inferior surface because they look from down. They look from down. They look at the inferior surface of the heart. Like it's very important, eh? Clear? Right? They look at the inferior surface of the heart. Understood, guys? Right? Now look here, guys. AVR is not significantly looking at the point, right? It has some other significance. We'll discuss that later in the class, in my proper ECG class. Right? Now we have said V1, V2 look at the septum, right? We have just said now V1, V2 look at the septum, right? V1, V2 look at the septum. V3, V4 is looking at the, right? V3, V4 is looking at the anterior surface, right? V5, V6 is looking at the lateral surface. Lead 1 AVL is looking at the lateral surface, right? Lead 2, lead 3 AVF, they look at the inferior surface. Why this is important? Why this is important? Tomorrow, right, if there is a change in the lead 2, lead 3 AVF, you should understand there is something going on the inferior side of the heart, right? Tomorrow, if there is a change in V5, V6, lead 1 and AVL, you should understand there is something going on the lateral side of the heart, right? So if there is a change in the V1, V2, V3, V4, you should be able to interpret there is something wrong in the anterior surface of the heart. Understood? So that's why this is important. That's why this is important. Now look at me. So now I have discussed about the 12 leads. Now I have discussed about the 12 leads, isn't it? Right? I have discussed about the 12 leads. Listen, look at me. I have discussed about the 12 leads. Now I have told you, right, these 12 leads are looking at the heart from different angles, right? So your V1, V2 looks like this, your V3, V4 looks like this, V5, V6 looks like this, your lead 1 AVL looks like this, lead 2, 3 AVFs looks from down, right? These 12 leads are looking at the heart from different angles. So these 12 leads will be able to pick up the problem from the area they are looking at. Understood? Now, what are the areas of the heart we have not looked? Right?
Posterior surface.
Not seen by our leads. Huh?
Posterior surface
Posterior
and the right
surface
ventricle.
of the heart.
Right. Now our leads, our traditional 12 leads are not looking at the posterior surface of the heart. Right? So we have not put anything to see the back, no. Right? We have not put anything to see the back. Similarly, the 12 leads, right? Our 12 leads are not looking at the right side of the heart. Understood, guys? Right? So our 12 leads are not looking at the right side of the heart. Our 12 leads are not looking at the posterior side of the heart. Just because our leads are not looking, right? Listen to me. Just because our traditional leads are not looking, that does not mean you can't have a problem in the posterior side of the heart. Like, just because we don't see in a normal ECG, just because our normal ECG does not pick up, it does not mean, right, your posterior surface cannot have a problem. It does not mean, right, your right side cannot have a problem. So to counteract this, right, to counteract this, whenever there is a suspicion, right, whenever you think, okay, something is going on the posterior side, right, something is going on the right side of the heart. So whenever you think there is a suspicion, you will tell the technician, right, you will tell the ECG technician, okay, can you do some additional leads, right? You will tell the fellow, can you do some additional leads, right? Can you do some additional leads? Can you do some additional leads? Okay, so how to do the additional leads, right? How to do the additional leads? Look here, guys. Like how to do the additional leads. Now, look here. Like the mirror image. Now, listen to me, guys. Look here. Right. This is how we put no V1, V2, V3, V4, V5, V6. Right. This is how we put no V1, V2, V3, V4, V5, V6. Right. Like we have put the V1 to V6. You can put, right? You can put leads on the other side, right? Like you have put here, you can put leads on the other side, like the mirror image to V1 to V6. You can put leads on the same way on the other side, like the mirror image to V1 to V6. right? So it's opposite to V1 to V6 on the other side. So now already we are given the name, no, right? Already we are given the name V1, V2, V3, V4, V5, V6. So since that name has been already taken, right? Since the name is already taken, for this leads, we are giving another name. We add an R, capital R, V1R, V2R, V3R, V4R, V5R, V6R. Understood? Right? Right? We are adding an English letter R. V1R, V2R, V3R, V4R, V5R, V6R. Understood? Right. So why do we put these leads? Why do we put these leads? Come on. To look at the right side of the heart. Why do we put these leads? To look at the right side of the heart. And Lamai, you can understand, it's too cumbersome, right? To put this much of leads on the left side, again putting this much of leads on the right side. Yes or no? Right? To put this much of leads on the left side, again asking the technician to put this much of leads on the other side also, it's too cumbersome, right? So because of that, generally we don't put all these leads. We ask them to put only this V4, right? Okay, right? Generally, right? We don't ask them to put all these leads because it's difficult, right? It's difficult for them also, right? 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 Okay, right? So instead of putting all these leads, we select one standard lead out of this group. That is your V4R, right? That is your V4R. Understood? Right? Okay. So that is the standard lead, right? You can ask the technician whenever there is a suspicion, can you do a V4R ECG also? Right? So the technician will put one lead here and take that recording as well. Clear? Because, right, if there is a ST elevation in the V4R, right, so we'll study later. This is called ST elevation. I will study in the second class, in the proper class, my session to Viva. This is the ST elevation. This is the ST elevation, right, right. If there is a ST elevation, right, in the V4R, I know what? I know what? This is a right ventricular infarction. Right, I know this is a right ventricular infarction. Understood? Right? Come on, guys. When we were students, nobody has taught us. Right? Like this V4 business, I was not even aware of the principle of the V4 business until I started my internship. Right? They never discussed about this in the faculty. Right? But if you know that, I mean, you are different. I better know these things, guys. Right? Proper knowledge is very important, even to understand and even to develop you further. So if you like cardiology, be a cardiologist. Right? It's always better. Right? Right? Fine, look here. Right? Listen. Right now. So now you can look at the right side now. Now you can look at the right side. Yeah. Now what side is pending? What side is pending? Posterior. So what you will do is you will put some lead in the back. You will put some lead in the back. You will ask to put some leads in the back. Right. Right. So when you suspect a problem in the posterior side, you tell the technician, can you put some leads right in the back? So we are going to call that as, look here, guys. Right. Right. So you are going to call these as, where is that? Photo. Okay. Right. There's a photo in the next presentation. Right. You put some leads in the back. Right. We put some leads in the back. So now we stopped in the V6 no. We stopped in the V6 no. Right here. We stopped in the V6 no. Right. We stopped in the V6 no. So the leads you put in the back, you will call it as V7, V8, V9. Right. You will call it as what? V7, V8, V9. V7, V8, V9. Right, you call this as V7, V8, V9. Clear? That is clear, right? So this is the same thing I told you, right? Lead 1, AVL, V5, V6, look at the lateral surface of the heart. V1, V2 is looking at the septum. V3, V4 is mainly anterior. Lead 2, 3, AVF is looking at the inferior, right? So AVR is non-localizing, right? Non-localizing, we'll discuss about it later, right? If I tell that in this, right? So V1 to V4 is the anterior, right? V1 to V4 is the anterior. What is the blood supply to the anterior part of the heart? Okay. What is the blood supply to the anterior part of the heart?
Blood.
Yes, left anterior descending artery, lead. Right. So if you have a problem in the V1 to V4, we know this is anterior, right? And the problem should be in the left anterior descending artery, lead. Right. V5, V6, lead 1 ABL, they look at the lateral surface. What is the blood supply to the lateral surface of the heart?
Left circumflex.
Left circumflex. Right, left circumflex. Right, left circumflex. So that tells you the problem is in the right left circumflex. Lead 2, 3 AVF looks at the inferior surface of the heart. Right, lead 2 AVF, inferior surface of the heart. What is the blood supply to the inferior cervix? Come on.
Right coronary.
Right coronary.
Right coronary. Right coronary is the one which is giving the posterior interventricular branch. Okay, clear. Right, look here. Right. So this right ventricle, right, is seen by your V4R, V5R, V6R, V4R, V5R, V6R. This is again by the right coronary marginal branch. Right, is again by the right coronary marginal branch. Okay. Like guys, who's making the noise? Right, again by the right coronary marginal branch. If you look at the posterior, right, that is by your V7, V8, V9, V7, V8, V9, right, that is by the right coronary as well as the circumflex artery, right, as well as the circumflex artery, right. The MI's pathologies I will discuss in a proper ECG class. I just want to give the basic introduction for this and the STEMI, ST elevation MI. Don't worry of the PVC and those things. I'll do in the proper ECG class. Look here. Right. So if I get this ECG, right? If I get this ECG, right, your mind should be tuned like this. Right? Right. Okay. So you should not look this as a piece of paper. Right? You should not look this as a piece of paper. Right? So you have to look like this. Right, okay, I am looking at the lateral side of the heart. This blue color, I am looking at the lateral side of the heart. Right, this red color, I am looking at the anterior surface of the heart. Right, I am looking at the septum of the heart. Right, understood, guys? Right, I am looking at the right green color, lead 2, 3 AVF. I am looking at the inferior surface of the heart. Right, clear? Right. So that's about that. Right, look here, guys. The next point. Right. Now, come on. Look here. Now, what is this current? Right. What is this current? Right. What is this current? Right. What is this current? So what is this current? Right. So there we have to have some idea about the conduction system of the heart, right? Conduction system of the heart. You may remember, right? Okay, you may remember, if you remember your conduction system of the heart, right? If you remember the conduction system of the heart, Right? If you remember the conduction system of the heart. Right? If you remember the conduction system of the heart. The electrical activity of the conduction system of the heart, you may be aware, is starting from a node called SA node. Right? It is starting from the node called SA node. Right? It's starting from a node called SA node. This SA node is there. Right? SA node is there. You may remember we call this SA node in a normal heart. This is the pacemaker of the heart. This is the pacemaker of the heart. This is the pacemaker of the heart. Right? So what do you mean by the word this is the pacemaker of the heart? In a normal heart, like it is discharging. What do you mean by the word discharging? It is sending the impulses at the higher frequency. Right? It is discharging. It is sending the impulses at the higher frequency than the rest of the heart. Than the rest of the heart. Right? In other words, the rest of the heart is suppressed. Right? Because if you like study in the proper ECG class, right, in the heart, every part can send discharges. Every part has an ability to send the current. Right? Every part has the ability to send the current. Right? But normally the rest of the heart is suppressed from sending the impulses because your SA node is discharging at a very high frequency. So the current which is starting from the SA node, right, it comes to a node here called AV node. It comes to a node here, right, called AV node. So it comes via these atrial muscles. Right? It comes via these what? Atrial muscles. Right? Now from the AV node, right, it comes to the ventricle. It comes to your ventricle. Right? This is your right. Right? This is your right atrium. This is your left atrium. Right? This is your right ventricle. This is your left ventricle. Right? Okay. So it comes to the what do you say AV node. Now my first point here. Listen to me. The only way for the current, right? Only way for the current or the electrical activity, right? The only way for the current or the electrical activity to come to the ventricle from the atria is via the AV node, right? Only way to come from the atria to ventricle in a normal heart, is via the AV node, right? In other words, AV node act as a gate, right? AV node act as a gate. Clear? It acts as a gate, right? So if you want to come from this house to this house, you have to come via this gate. You have to come via this gate. Later in a proper ECG class, we'll study. This is just the introduction, guys. Right? This is just the introduction. Can't teach the whole ECG here. It will cost me about 10-20 million loss. Right? Oh, about just imagine for another 10-15 years that class. Right? Okay. Look here. So in a normal heart, that is a gate. That is a gate. Right? So, right, later we'll study in some abnormal condition, you can have a abnormal pathways. Right? In some abnormal condition, you can have abnormal pathways. Right? There can be some abnormal pathways. Right? There can be abnormal pathways. Right? Instead of going from the gate, you can just jump through the wall and go no. Right? Right? So those are the mechanisms to have some arrhythmias. Right? We'll study later. Those are the mechanisms to have arrhythmias. So this is coming from the SA node to AV node. Right? From the AV node, it comes here, right, to the His bundle. Right? AV node comes to the His bundle. Right? His bundle, His bundle, His bundle. Right? Right? His bundle, the good old days anatomy. Right? You may remember this His bundle divides into two, isn't it? Right? What are two bundles? Huh? Right and left. Right and left. It divides into two, right and left, right and left, right and left, right and left. Right? Actually speaking, this left also divides into two. Right? Left bundle also divides into two. Right, left bundle also divides into two. Right, left bundle also divides into two. Right, left bundle also divides into two. So this divides into right and left. Right, then it is giving some small branches, isn't it? Small branches. Right, so how do you call these? Like these are your Purkinje fibers, isn't it? These are the Purkinje fibers. Purkinje fibers. Right, Purkinje fiber. Right, Purkinje fibers. Understood? So in a normal heart, the current is going from SA to AV node via the atrial muscles. So AV node is the gate and it comes via the AV node to the his bundle. It divides into right and left. Right, actually the left has another two branches. Then each branch off giving small things. Right, so those are your Purkinje fibers. This is how the electrical activity of the heart is there. So, right, okay. This is how the electrical activity of the heart is there. Right? Yeah. Fine. Okay, fine. So, what do we want to see in a normal ECG, guys? Right? What do we want to see in a normal ECG? So, before starting a normal ECG, right, that is not the purpose of the class that we study in the purpose class. You might have seen an ECG paper. Right? You might have seen an ECG paper. So, those who have seen the ECG paper, right? Those who have seen the ECG paper, right? Those who have seen the ECG paper, right? You might have seen, right? This is how they are now. There are small boxes. There are small boxes and large boxes. There are small boxes and what? Large boxes. Like small boxes and large boxes. Right? So you might have seen the paper is running like this, isn't it? The paper is running like this. Right? The paper is running like this in a machine, isn't it? The paper is running like this. So when the paper is running like this, Mama, look here. Right? When the paper is running like this, right? Okay, paper is running like this, right? Running like that. I'll discuss in the next class properly. What is here, guys? What is this axis? What is this axis in maths? What is this axis?
X-axis.
X-axis. This is the x-axis. What is this axis?
Y.
This is the y-axis. This is the y-axis. So what is running in the x-axis is, right? What is running in the x-axis is, right? Your x-axis, you are running the time. Right? X-axis, you are running the time. So x-axis, you are running the time. Right? In the y-axis, right? In the y-axis, right? In the y-axis, right? You are plotting the voltage. Right? Voltage. Right? X-axis, you are running the time. Right? In the y-axis, you are plotting the voltage. Right? I'll discuss about a lot about this in the next class, but just to show you some small points. Right? Y-axis, you are plotting the voltage. Right? So normally, guys, look here. Right? We'll discuss later this. Normally, your paper is moving at the speed of 25 millimeter per second. Normally, your paper is moving at the speed of what? 25 millimeter per second. Normally, the paper is moving at the speed of what? 25 millimeter per second. Right? Normally, the paper is moving at the speed of what? 25 millimeter per second. When the paper is moving at the speed of 25 millimeter per second, right? When the paper is moving at the speed of 25 millimeter per second, this every small square here, this small square here, this x-axis, right? The small squares in the x-axis, this is 0.04 second. This is what? 0.04 second. In other words, right? In other words, This is how many milliseconds?
0.04 milliseconds.
This is 0.04 second. 0.04 second. How to convert that to millisecond? You have to multiply by 1000. Right? This is 40 milliseconds. Right? This is 40 milliseconds. Right? This is 40 milliseconds. Right? So what is running in the y-axis is, right, your voltage. Here, every small square in the vertical, every small square in the vertical is 0.1 millivolt. 0.1 millivolt. 0.1 millivolt. Clear? One. Okay. And the best part is the next part of the class. This is just the introduction to say what is PQRS. Right? Look here. Now, if you look at the ECG, from the good old days, you may remember, right? You might have heard the word, how does a normal ECG looks like, right? So you may be aware, right? Okay, you may be aware, right? You may be aware, right? Right? Okay. There is a wave called P wave, isn't it? P wave. So any deflection, look here. We say this is the baseline, no? This is the baseline. Any deflection upward is called what? Positive deflection. Right? Any deflection upward is called positive deflection. Any deflection downward is called what? Negative deflection. Right? So this is a P wave. Then you have a complex called QRS complex. QRS complex. Right? QRS complex. What is the Q wave? It's not always there. It is not always there. It's only at some points it's there. What is this Q wave is? This is the first negative deflection after P wave. Negative, no? This is negative, isn't it? This is negative. This is negative. Right? This is the negative deflection. This is a negative deflection. You got my words, right? 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 This is a baseline. What is going in this way is called negative. What is going in this way is called what? Positive. Right? So what is this Q is? The negative deflection after the P wave. And the next positive deflection, this is a positive deflection, no? This is a positive deflection. This is called R. This is called what? R. Right? Then again you have a negative deflection. Again you have a negative deflection. That is called S. That is called S. That is your QRS. Right? That is your QRS. Right? That is your QRS. QRS. Understood? Then you have something called T wave. You have something called T wave. You have something called T wave. T wave. Right? Then sometimes you see a small wave called U wave. Sometimes you see a small wave called U wave. Right? U wave. Okay, look here. Now, what is this P wave, guys? Okay, what is this P wave? Right? This P wave is, what does this denote? So you are aware, when the SA node discharges, like this is your heart, no? This is your heart, right? Right, this is your heart. Right? When the SA node discharges, it's like this, no? It's like this. Right? So area is depolarizing. Right? As a response, atria is depolarizing. Atria is depolarizing. So what does this P wave, right? Okay, indicates is this P wave is representing the depolarization of the area in response to SA node discharge or triggering. Right? This P wave is representing the depolarization of the area in response to SA node triggering. Okay. Right? Depolarizing, yeah, depolarizing. Now, what does the QRS indicate? So when the current comes to the ventricles, right? When the current comes to the ventricle, right? When the current comes to the ventricle, clear? So, like when it comes to ventricle, we know from the his bundle and Purkinje fibers, your ventricle will depolarize. From the his bundle and Purkinje fibers, ventricle will depolarize. No, ventricle will depolarize, isn't it? Right. So, what does the QRS represent? This QRS is representing the depolarization of the ventricle. Right. The QRS is representing the depolarization of the ventricles. Understood? Right, look here. Now I look here. Right, so it's depolarized, depolarized, depolarized. Whatever depolarized, it should come back to the normal stage at one point, no? Right, if it is depolarized, it like electrically it is depolarized. The voltage changed. Voltage has changed. Whatever the voltage has changed, it has to come back to the normal stage, no? Yes or no? Right. So how do you call that? Coming back to the normal stage is what?
Depolarization.
Repolarized, isn't it? This is depolarized. That is repolarized. Repolarized, isn't it? So what does this T wave? What does this T wave indicate? What does it denote is, this is denoting the ventricular repolarization, right? This T wave denotes the ventricular depolarization. Clear? Okay. Somebody listen to me. Right? Fine. Now look here. Right? Kids, are you okay? Are you okay? Like about the abnormalities and everything I will discuss in the proper ECE class. It is part of the session 2 Viva. Right, look here. Listen here. Now, right? Come on, look here, guys. This is the P wave. This is the P wave. This is the QRS. Right? This is the P wave. This is the QRS. This is the QRS. From the start of the P wave, from the start of the P wave, from the start of the P wave to the start of the QRS, from the start of the P wave, right? From the start of the P wave to the start of the QRS. This we call as PR interval. Right? This we call as what? PR interval. Right? This we call as PR interval. Clear? PR interval. PR interval. All the students who are sitting for the theory and the juniors, make sure you finish off the theory class as soon as possible. The restreaming is continuously going. Finish off the theory class as soon as possible. Right? You will never pass the exam without attending the theory class. It won't happen at all. Right? It won't happen at all. Right? Make sure you finish the theory class as soon as possible. Right? Even the juniors, if you attend, right, you can use the same attendance and come any number of time. So don't cut that. And regularity is also important. Right? Okay, look here. This is a PR interval. So if you look at this PR interval, the PR interval is mainly determined by, right? PR interval is mainly determined by, right? For the current to go from the atria to ventricle, for the current to go from the atria to ventricle, I told you how does it go? How does it go? Via what? Via the AV node. Via the AV node. Via the AV node. Right? Okay. Look here, guys. So if you look at this AV node, right? If you look at the AV node, this AV node has an inherent delay. This AV node has an inherent delay. So there is a delay that is inborn with the AV node. right? There is a delay that is what? Inborn with a AV node, right? This AV node has an inherent delay, right? It's an inborn delay. So this inherent delay of the AV node is the main one which determines your PR interval. Clear? Right? Because it's very important to know that, because in a proper ECG class, in the Viva class, we'll study, right? So if the PR interval is prolonged, we are going to call that as first degree heart block. Right? We'll call that as a first degree heart block. Right? Right? So what is determining the PR interval? The inherent delay of the AV node. Right? Okay, look here, guys. Before going to the next part of the class, I just want to say two more points before going to the second part of the class. From the start of the QRS here, from the start of the QRS, right, to the end of the T wave, from the start of the QRS to the end of the T wave, from the start of the QRS to the end of the T wave, right, you call this as QT interval. Right, this is your QT interval. Right, so this is your QT interval. This is your QT interval, QT interval, QT interval. So what is this QT interval? This is starting from the start of the QRS up to the end of the T wave, QT interval. Clear? Come on, look at me, guys. Look at me. Look at me. Are you okay? What is QT interval? Right? Right? The good old days in psychiatry, we have studied some drugs. These drugs are prolonging the QT interval. Right? These drugs are prolonging the QT interval. This is that QT interval. Right? You study this TCA, antipsychotics, etc., etc. Right? One of the side effects of those drugs is they can prolong the QT interval. This is that QT interval. Clear? My next point. Right, Lama, look here. This QT interval, the point about this QT interval is, this QT interval depends on your heart rate. Clear? So, right, this QT interval depends on the heart rate. In other words, right, when the heart rate changes, the QT interval changes. When the heart rate changes, what is changing? Come on. QT interval changes. QT interval changes. Since the QT interval is changing with the heart rate, ideally speaking, we have to adjust the QT interval according to the heart rate. Right? We have to adjust the QT interval according to the heart rate. That's why we are using a term called QTC. Like QTC. C for corrected. Corrected. Right? QTC. What does this C stands for? C stands for corrected. Right? So there are formulas, there are online applications, right, where you enter the heart rate that will tell you for this heart rate, this should be the QT interval. Clear? For this heart rate, that should be the QT interval. Right? For this heart rate, that should be the QT interval. Clear? So do we have to know about the EEG also? Not at all. Not at all. Right? Tomorrow, if you are doing neurology, let me know. I'll do a EEG class. Right? Right? Nobody else, you don't have to know at all. Right? Right, look here. Right? Better you don't know, because otherwise you will try to interpret the EEG. It's a disaster for us. Right? Okay, look here. Right. Where are we? Yeah, QTC. So roughly we are saying, guys, like roughly. Right? So roughly we are saying, like if the QT interval is more than 440 milliseconds in a male, 440 millisecond in a male, or more than 460 in a female, that is prolonged. I will discuss later. Right? If the QT interval is more than 440 millisecond in a male, or if it is more than 460 in a female, right, that is prolonged. That is prolonged. But it's a rough thing. That's a rough thing. Right? QT interval changes with the heart rate. That is not the case in the PR interval. Right? We don't talk about the PRC. Right? We don't talk about the PRC, but we talk about the QTC. Right, we don't talk about the PRC, but we talk about the QTC. Like QTC. Like QTC. Understood? Right? Are you okay? Like, just know the QT interval changes with the heart rate. Right, let me look here. So can you see here? I just want to say this is my last point to finish on this one. Right? Right, look here. Right? This part, guys. Right? This part. This part. Like this part. This part. This part. Like this part. Like this part. This part. This part. This part. Right? Okay. This part. This part. This part. This we call as ST segment. Right? ST segments. Right? This ST segment is, it should be in a normal heart, this ST segment should be isoelectric. Right? In a normal heart, this ST segment should be isoelectric. What do you mean by the word isoelectric? Right? Right? What do you mean by the word isoelectric? Huh? Come on. It should not go up. It should not go down. Yeah. It should not go up. It should not go down. Clear? So if it is go up, we'll study in a few minutes. That is called ST elevation MI. Right? If it goes down, you will tell that is ST depression. ST depression. Understood? In a normal heart, like this should be isoelectric. Clear, guys? So that's about the basic ECG I want to say. Right? We'll discuss about the abnormal ECGs, right, later in the proper ECG class in the Viva. Listen to here. Clear? That's okay now? So with that introduction, I'll move on to the next part of the class, our cardiac integrated what class? Is that? Okay. Fine. Right, integrated what class? Come here. A common cardiac person, I mean, those who have stated the last night, right, for the thing also you might have, right, I have discussed a similar thing, right? Right, okay. Well, so what is this integrated word class series? Also attended last time, you may have some ideas, right? What is this integrated word class series? We'll take the common scenarios, common patient presentation, right? And we'll take on discussing on that. Clear? So this is not falling into the theory class. This is not falling into the Viva class. This is not falling into the emergency class, but this is a proper medicine class, right? Okay. So we'll talk the proper full-blown medicine here, right? It's not only for the exam purposes, but also for the life purposes. Clear? Look here. So we start with, I just want you to be active here because it's a very common scenario in the Viva, very common scenario in the theory, and it's a very common thing in the emergency. 1 in 3 will get this in emergency, right? So, like maybe the people who are usually active right now, like if you're sleeping, just wake up at this point, right? Okay. We'll start from the first scenario, like the first scenario, this is how it starts, right? So, yeah, now there is you are the house officer there, right? You are having a patient in front of you, right? Like there is a patient in front of you. His name is Mr. X, right? His name is Mr. X. Clear? He is 52-year-old, right? He is 52-year-old, right? So if you look at his background, in the background, he is having diabetes, type 2 diabetes, right? He is a diagnosed patient with a hypertension, right? And he is also having high cholesterol. This is his background, right? This is background with a diabetes, hypertension, and high cholesterol, right? This patient is there in front of you, right? Okay. So now you have some idea about the patient now, right? Yeah, right. Look here. Why has he come now? Right? He's there in front of you at what do you say, 11 o'clock, right? Right. Okay. He's telling you, I don't know, what's the time he's there in front of you? I have not mentioned that. Okay, doesn't matter. Now he's telling you, right? Why did you come? You're asking him, why did you come? doctor, I'm having chest pain. Right? Yeah. He's there in front of you at 11 o'clock. Right? 11 o'clock, he's there in front of you. He's telling you, why did you come, doctor? I'm having chest pain. I'm having chest pain. Okay, chest pain, right? Okay. At what time it has started? Oh, it started at 8 o'clock. It started at 8 o'clock. Right? Okay. So you are the doctor, right? Patient is in front of you. It started at 8 o'clock. He has come with you with a chest pain. Right? Okay. So you further ask him, okay, chest pain, okay. Right? So, right, okay. Right, chest pain. Okay, right. So what will you ask, guys? You tell me, what will you ask? What will you ask? Tell. I mean, yesterday also discussed that.
Duration of the chest pain, the character of it, duration, character, to point and show where the chest pain.
You asked me. The duration of the chest pain, yes, doctor, it has started at 8 o'clock. Now it's 7 o'clock time, 8 o'clock. What else you want to do?
Can you show us where is it?
Yeah.
Yeah, the pain is here, doctor. Right, the pain is here. Right, he said the reverse chest pain. Right, the pain is here, doctor. He said the reverse chest pain.
What were you doing when you got the chest pain?
Doctor, actually, I was driving that time, but I stopped the vehicle and I came here.
Did it fade to anywhere?
I can hear you.
The character of the chest pain.
Doctor, it is like a tightening type of pain. Like the pain is very tightening. It's a tightening type of pain.
Did the pain radiate to the neck, shoulder?
Doctor, not to the shoulder, but I had some pain here also. Right, it went there as well. Right.
What is the duration?
Doctor, I told you, no, doctor, it's started at 8 o'clock. It's still, it's paining.
When you stopped driving and started resting, did the pain reduce or anything like
Doctor,
that?
I didn't try that. Right, I just stopped the vehicle and came here in a 3-wheel.
Was there any associated sweating?
Yeah, doctor, you're right. Actually, I was sweating a lot. Right, I was sweating a lot.
Nausea, vomiting?
I didn't vomit, doctor, but I was very nauseated. I thought I'm going to vomit, but I didn't vomit, but I was nauseated anyway. Yeah.
Was the pain relieved on bending forwards or did it radiate to the back?
Actually, doctor, I didn't try that. I'll try and tell. Right.
So you want us to ask questions to exclude differentials also?
No, okay. Yeah, ask something. No, that's enough. Right. Okay. Now, like this patient is having acute chest pain, isn't it? This patient is having acute chest pain. This is an acute onset central chest pain, right? Acute onset central chest pain. From my description, what is this pain?
Ischemic.
It's a ischemic pain. From my description, this is an ischemic pain. Yes or no? It's an ischemic pain because it's a exhaustional pain. It's a constrictive type of pain. It is radiating to my neck. I was sweating. I was nauseated. From my description, this is an ischemic pain. It's not a Viva class, just for you to get back to the ECGs. Understood? Right, look here. Right now, what do you want to see in your examination? I'm in front of you. What do you want to see? What will you do now? What will you do now?
Acute side bed.
You want to put me to the acute side bed, okay?
Connect to a monitor.
You connect me to, okay, I'm connected to the monitor now.
ABC.
ABC, I'm giving you a good history, right? So my airway should be okay, right? I'm still talking, so the breathing should be okay, right? Right? You check my circulation, you check my pulse and blood pressure, right? That will give some idea about my circulation. Okay, what do you want to do?
Order ECG with additional leads.
So you are going to order an ECG, very good. You say you are going to order an ECG. Okay, we are calling and ask them, okay, just come, right? We have an urgent case, right? This fellow taught us in the medicine class also, right? Better kill now itself, right? Right, come, right? But they will be delayed. Okay. What's the next thing?
Emergency drugs. Emergency drugs.
You are telling you are going to the emergency drug. I'll come back to this point again. Right. So these are the findings, right? Okay. So I tell you the findings. The general examination is normal. Okay. The general examination is normal. We have connected the patient to the pulse oximetry where the saturation is showing as 97%. Right? So the pulse is 88, which is regular. Right? Pulse is 88, which is regular. You are checking the blood pressure. The blood pressure is 140 by 80. 140 by 80. Right? You check the JVP, jugular venous pulse. It is not elevated. Right? It is not elevated. It is not elevated. Clear? Right? So the first heart sound, second heart sound, both are normal. Both are normal. Both are normal. Right? So you look at the lungs because you know this is a heart attack. You know this is a heart attack. This is an MI, acute coronary syndrome. So it can be complicated with the heart failure. Right? It can be complicated with the heart failure. This is a heart attack. It can be complicated with the heart failure. So you look at the lungs, you know, if you look at the lungs, there are a few crepitations at the basis, right? There are a few crepitations at the basis of the lung. The rest of the examination is actually normal. Like the rest of the examination is actually normal. Okay, right, look here. So what is your clinical diagnosis now? It's not a big difficulty. What's a big difficulty? Come on. This is what?
Coronary system complicated with
Acute. Answer, guys.
Coronary syndrome.
Acute coronary syndrome. What is your clinical diagnosis? This is the acute coronary syndrome. Right? This is the acute right coronary syndrome. This is the acute coronary syndrome. This is what in layman terms, right? They call it heart attack. Right? Okay. Right? Okay. Layman term. This is the heart attack. This is the heart attack. Right? Right? Clear? Understood? Right? So this is acute coronary syndrome. Come on. Now, what is your next step? What is your next step? You said correctly. You want to put me to the bed. Okay, right, done. You want to connect me to the cardiac monitor. Done. You have ordered the ECG, okay, we have called the ECG and we have asked them to come, done, right? You have checked my ABC, airway, breathing, circulation. You said you want to check that, it's done, right? It's done, right? It's done, okay. Now, what else you want to see, guys? What else you want to do? Tell.
Give the emergency drugs, aspirin, clopid, morphine.
You want to give the emergency drugs. Right? You want to give the emergency drugs. What are the emergency drugs you are going to give? Tell.
Aspirin 300 milligrams,
Aspirin 300 milligrams,
clopid 300,
300 milligrams,
morphine
80 milligrams. I am in pain, so you can give me morphine with the metoclopramide. Okay. So this is the management. Right? This is the management. Acute side bed. Connect to the cardiac monitor. I don't need oxygen because my saturation is 97%, right? You will give oxygen only if the saturation is less than 90%, otherwise you don't give, right? You take the blood for the test and the CBS, right? CBS, okay, check the sugar. You have ordered an urgent ECG, and you are given the initial drugs. What are the initial drugs? Like we studied in the theory, we studied in the Viva, by this time you should know. The kids, you are not studied the theory, they're very small kids, don't worry, yeah? You study this in the theory class and Viva class. We are too small here, right? Don't worry, right? You have time, right? In the theory and Viva, we'll discuss this, right? Okay, look here. So if you look at the initial drugs, aspirin 300 milligram, clopidogrel 300 milligram, we are giving atorvastatin 80 milligram, right? IV morphine 5 milligram, right? So this morphine can cause nausea, vomiting. So in such a case, we may give some Maxilon also. Okay. So you are given the initial drugs. Yes or no? Initial drugs done. Given. Now what are you waiting for now?
Wait for the ECG.
ECG.
You are waiting for the ECG. Okay. ECG has come. This is the ECG. Look at the ECG. This is a real scenario, eh? Why? This is a real scenario actually. Right? Look. You want me to enlarge? This is lead 1. This is lead 1. This is lead 1. Right? This is the lead 1. Actually, I went to the ward. I took the history. I took the ECG photo. This is a lead 2. This is a lead 2. The kids will study, don't know yet how to interpret this. There's a class in the Viva session 2. This is the lead 3. This is a lead 3. This is a lead 3. Right. This is your AVR. Right. Okay. And this is your AVL. And this is your AVA. This is the AVA. Right. This is your V1. This is your V2. V1. V2. Right. This is your V3. I think V3. This is your V5, V6. This is your V4, V5, V6. V4, V5, V6. I'll come back to this again. Is it clear? Okay, right? Images is not that clear though, but it's you can understand. Right, because I'm checking in my iPad also now. Right. Right. Okay. Done. Anybody wants to tell the diagnosis?
Anterolateral STEMI.
Anterolateral STEMI or anything else?
Inferolateral.
Inferior STEMI. Okay, somebody said a good answer. Inferior STEMI. Right, inferior STEMI. Okay. Anybody else want to add anything? I'll come back to the answer anyway. Inferior STEMI. Some are saying it's an inferior STEMI. Some are saying it's anterior STEMI. Any other answers?
Extensive.
Any other answers?
Can we see the ECG again?
I'll put it again back. Wait a minute. Give me a second. Virtual. Okay. Okay, look here. Because these are additional classes, free classes, right? You have to come and time. I don't encourage a message saying that will you restream, right? Those things I'm not bothered at all because we don't have 5-6 students now, and we are not teachers who are teaching 25-30 students. We have 500-600 students, 1,000 students in our class, right? And even if you don't come to class, one day you will come, right? So we can't come behind you, right? So don't send me stupid messages. Will you restream and those things? Those depends on my mood. Right? If I am having a good mood, I will restream and those things. But those things I'm not even interested in this, right? I'm having that personal work. I can't come. Will you restream? No. If you want, you have to come behind me. It's not me who has to come behind you. Done? Okay, I'll come back to this ECG at the end. Yes, seen? No? Yes, seen. Okay, I'll come back to this. Look here, guys. Right? So this I have discussed. This I have discussed how to put. Come on, look here. So this you know, no? This you know. Right, this we have discussed, no? Yeah, this is the one I told you, the posterior leads. Right, I told you we are putting the posterior leads to look at the back, no? V7, V8, V9. Right, this is how you put the posterior leads. I'll come back to this point again. Right, this is the one you put the posterior leads. Now I look here. Just a few words about this ST elevation MI. Ramai, right? Listen here. Now, say there is a patient in front of you. There is a patient in front of you, right? Right. This is a ST right patient. So this is a P wave, right? This is a sorry. This is the R wave, S wave. Right. This is your R. This is your S. This is your T wave. Right. This is his ECG. He is perfectly well sitting in front of you. He is perfectly well sitting in front of you. Clear? Right? He has come for some other problem. He has come for some other problems. Right? He has come for some other problem. So you are talking to him. He's connected to the cardiac monitor. Right? He's connected to the cardiac monitor and you are talking to him. Right? You are something odd, so he developed an MI. Right? You are something odd, so because of that, he developed a heart attack. Clear? So what heart attack he has developed? He has developed a, right? This is your ST segment, no? This is your ST segment, isn't it? ST segment. ST segment. I've discussed data in the EC class. This ST segment has gone up. ST segments have gone up. You call it what? If the ST segments have gone up, you call it what? ST
elevation.
ST elevation MI. He developed a ST elevation MI just by talking to you, right? And he is anyway connected to the cardiac monitor. So you are looking at the cardiac monitor. You are looking at the cardiac monitor. From here to here, it will not happen like this, right? This is not something happening like this, right? This is not something happening like this. Understood? So how this evolves is, guys, look at me, guys, look at me. So now we imagine this patient is going to have a heart attack. This patient is going to have a heart attack. So when this patient is going to have a heart attack, right, STEMI, what is STEMI? ST elevation MI. First, his T waves will become 2. Right, the first thing will be what? T waves will become what? Told. We will call this as hyperacute T waves. We'll call this as hyperacute T waves. You may remember, we discussed in the cardiology theory class, right? Hyperacute T waves. Then what will happen is after some time, this is the ST segment, so this is the ST segment, this is the ST segment. This ST segment will start to go up. After some time, this ST segment will start to go up. Right? This ST segment will start to go up. Right? Okay, it will start to go up. That's what you call as what? ST elevation. Come on, guys, answer. MI. ST elevation MI. Then what will happen is, this ST segment which has gone up will come down. Sometimes this will come down, this will come down, this will come down, this will come down, this will come down. When it comes down, the normally T wave is like this, no? Normal T wave is upward, no? Normal T wave is like this, isn't it? Upright. Right? So later your T waves will be, right, inverted. It will become like this, inverted. So if you don't do anything, right, if you don't treat the patient, sometimes he can develop something called Q wave here. Sometimes he can develop something called what? Q wave. There's a wave called negative wave, Q wave here. The mechanism of this we study in the cardiology theory class and the Viva class and the emergency class we'll discuss. Right? We'll discuss. I just want to tell that to start all this, just to revise your theory knowledge. Right? So you may remember, if you look at the changes in an ST elevation MI, right? ST elevation MI, the hyperacute is tall peaking T waves with a progressive ST elevation. The T waves will become tall first with the ST elevation. Then you have ST elevation. It's like this, guys. It's like this, right? Okay. It's like this. Right? It's like this. Right? Look here. This is how it starts. This is how it starts. This is the normal ECG. Now we are going to develop a heart attack. Look here. The T waves are becoming tall. T waves are becoming tall. T waves are becoming tall. Clear? Okay. Now look here. Your ST segment is going up. Your ST segment is going up, going up, going up. Now look here, right? Your T waves are now inverted and you are developing a negative wave. Look here, there's no Q wave here, right? Here, at the start, there is no Q wave. Right? At the start, there is no Q wave, no. At the start, there is no Q wave. Now you are developing a negative wave. This is the Q wave, Q wave, Q wave, Q wave, Q wave, Q wave, right? So the Q wave is there means permanent damage has occurred. Permanent damage has occurred. Right, now look here, right, there is a Q wave and the T wave normalizes. Clear? These are the changes that occurs in a ST elevation MI. Okay, now look here. Before coming to my ECG, I'll come back to the few ECGs. At the end, I'll come to our patient. Now, what is he having here? What is this patient having? Come on. What is it? From what I have said, that's enough to understand. What is this patient having? Come on.
Anterior STEMI.
Huh? Yeah, you are good. It's anterior STEMI. Why do you say it's anterior STEMI? Look here.
V4,
V3, V4. There is a ST elevation with the hyperacute, tall T waves. Am I right? Come on, guys. Kids, are you okay? The very small kids, don't go here. You have some idea now, will you? Right? When you come to theory class, Viva class, you'll understand. Right? Okay. Right? Do you understand that? There is a ST elevation in the V2, V3, V4. V2, V3, V4 are what leads?
anterior leads.
Anterior. Anterior. So what is this there in the ECGs? Look here, guys. Right? What is there in the ECGs? Right? What is there in the ECGs? Look here. There is a ST elevation with the right hyperacute T waves, right? Hyper in V2 to V4. Clear? Right? In addition, right? I think there is some ST elevation in there, right? Where are we? Lead 1 AVL, is it there? Yeah, lead 1 and AVL also, there is an ST elevation. Right, there is a lead 1 and AVL also, there is a mild ST elevation is there. Right? So Q waves are there in the V1, V2. So these are hyperacute anteroseptal. V1, V2 is anteroseptal, no? Anteroseptal MI. This is hyperacute anteroseptal MI. Now look at the next ECG. Then can make it? What is there? Tell. Answer. Look here and answer.
ST elevations.
ST elevation where?
V4, 5.
V4, 5, okay.
3.
V3 and V2, isn't it?
Hmm.
And V1, V2, what is this negative wave, guys? What is the negative wave this is?
Q wave.
Q wave, isn't it?
Q wave.
This is your Q wave. This is your Q wave. So what is the diagnosis? What is the diagnosis? Answer.
Anterolateral.
Anterolateral MI.
Lateral MI.
Yes. Why do you say lateral?
Because
V5
V5 and
What is
V6.
this? What is this? What is this?
V6.
What is this? Huh? What is this?
V1.
AVL. This is AVL, isn't it? This is lead 1. Right? AVL and lead 1 also there is a ST elevation. Can you see the elevation here? Can you see the elevation here? Yeah? Yeah? Okay.
Yes, sir.
So what is this ECG is? Look here. There is a ST elevation. There is a ST elevation. Right? There is a ST elevation and Q waves in V2 to V5. Now ST elevation is also there in lead 1 and AVL. Lead 1 and AVL. Right? There is some reciprocal ST depression in the lead 3. Understood? So that's okay, no? Right. Sorry. Next one. Amai, look here carefully. Right, okay. Look here carefully. You are not going to answer. Look here. Right. What do you see?
Inferior.
Inferior. Why do you say inferior? Why do
2,
you say
3 and
inferior?
2,
Now,
3 and
already we have
AVF.
discussed inferior MI changes will be behind what leads?
2, 3
3
and
and
AVF.
2,
Road
3
lead
AVF.
2, lead 3, AVF. Lead 2, lead. So what do you see here in the lead 2? Come on, guys. What do you see here in the lead 2? Answer.
ST elevation.
ST
ST elevation.
elevation. What do you see here in lead 3?
ST elevation.
Elevation.
ST elevation. What do you see here in AVF?
ST elevation.
ST elevation.
Again, ST elevation.
ST elevation. So what is the diagnosis? Anil, are you all okay?
Inferior MI.
Inferior MI.
Inferior MI.
Inferior MI.
Yeah, ST elevation. I'll come to this. Okay, well. So what is inferior MI? There is ST elevation in the lead 2, 3 AVF. There is ST elevation in the lead 2, 3 AVF. Lead 2, 3 AVF. Make sure the cameras are on, man. I can't tell you again. Right? You will just remove from the meeting. Right? ST elevation in the lead 2, 3 AVF. Clear? So before the ST elevation, they can have a hyperacute T waves. We have discussed because there is a mechanism, and there can be a reciprocal AVF, ST depression in the AVF. Progressive development of the Q waves. Right? If the MI progresses, they can develop Q wave. Right? Q wave. So if you look here, if you look at the lead 3, can you see the Q wave? Right? This is the, what wave is this? What wave is this? Negative wave is
Q
what?
wave.
Q wave. Right? Q wave. Right, Lamai. I just want you to tell a few points here. Right? I just want you to tell a few points here. Listen to me. Remember, this inferior MI, right? This inferior MI, it can be associated with a right ventricular MI. Right? This inferior MI can be associated with a right ventricular MI because, now look at me. You may remember the point I have discussed earlier. What is supplying the inferior surface of the heart?
Right
cardiac
interventricular.
Right.
Posterior intervention.
Posterior interventricular artery. This posterior interventricular artery is a branch of what artery?
Right coronary artery.
Right coronary artery. So the inferior MIs are due to right coronary artery problem. Right coronary artery problem. So they can have a right ventricular MI as well, no? They can have a right ventricular MI as well, no? Yes or no? Right. Now look at me. Now what is the point we studied earlier? What is the point we studied earlier?
Can have conduction problems and
Yeah,
affect
before that. Normal ECG is not looking at the normal
Posterior straight of the heart and the
ECG is not
right
looking at
Posterior
the
right.
right side
Right
of
side.
the
normal ECG is not looking at the right ventricle. So if you want to look at the right ventricle, tell me the lead you want to put.
V4R.
V4R. Very good. V4R. Tell me the lead you want to put. You will tell the technician, can you put a V4R and take an ECG? Can you put a V4R and take an ECG? Yes or no? Are you okay up to this point? Yes or no? Right. Now, inferior MI, there can be associated right ventricular MI. So right ventricular MI, we had to put the additional lead to look beautifully. What is the additional lead? V4. Are you okay? Come on, guys. Understood. Now, when will you suspect a right ventricular MI? There comes a theory class. When will you suspect a right ventricular MI? That's a theory class knowledge. Answer.
When the inferior leads show something in the
No. Clinically, when will you suspect a right ventricular MI?
epigastric pain.
inferior.
When will you suspect?
When heart
Hypertension with associated in the JVP.
Hypotension with the
Tension, no beat.
elevated JVP. When you suspect hypotension with increased JVP, right? If the patient is having hypotension with the elevated JVP, right? If the patient is having hypotension with the elevated JVP, that is the point we suspect a right ventricular MI. Understood? Understood?
Excuse me, sir.
Yeah.
Sir, if they present with clinical symptoms of features of pancreatitis, also don't we suspect an inferior MI?
So yeah, there you suspect inferior MI. I'm not asking for the inferior MI. I'm asking for the right ventricular MI. Right? What is it?
Yeah.
Right? Yeah. Hypotension with the elevated JVP. I just want to tell an MCQ point, guys. Right? I just want to tell an MCQ point. Now, kids, are you there with me? Tell another drugs you are going to give for chest pain when somebody comes with chest pain. Tell another drugs you are going to give for chest pain when somebody comes with nitrates, isn't it? Nitrates, right? GTN, ISMN. Remember, these people can develop severe hypotension when you are giving nitrate. These people can develop severe hypotension when you are giving nitrates. Right? Right? Okay. These people can develop severe hypotension when you are giving nitrates. Understood, guys? Am I listening to me? Why I am telling this? Why I am telling this? Am I look here? Right? People, I told you several times, right? So there is no reason for me to do this class, no. Right? This is not in the theory class, this is not in the Viva class, this is not a paid class. There is no reason for me to do this class. Like the only reason for doing the, and there's no need to come and advertise here to our theory class and Viva class. You'll anyway come. Like we passed that stage once upon a time. The only reason for doing this class is just to make sure better and better. So my message to you, tomorrow you are the house officer. Like tomorrow you are the house officer. Clear? There is a patient with a chest pain. Right? Patient with a chest pain. You are given some nitrates. GTN, no, ISMN, no, ISBN, no. You are given some what? Nitrate. You are given some nitrate. So when you give the nitrate, the blood pressure has crashed. Right? Suddenly there is a drop in the blood pressure. Right? When you give the nitrate, blood pressure has crashed. Right? Understood? Blood pressure has crashed. When the blood pressure crashed, right, I want a good student, right, to think, okay, can this be a right ventricular MI? Clear? Can this be a right ventricular MI? Understood? Right? So normally, no, blood pressure is not crashing in each and every patient. Like how many patients we are giving nitrates? Is the blood pressure is crashing? No. Right? So if the blood pressure crashed tomorrow, like you should click to you, right? Can this be a right ventricular MI? Understood? Right. Now look at me. So that's the reason for this class. Otherwise, it's a wastage of time. Right? Right. Look here. Listen. Now look at me. Now, this inferior MI. What is the other point you told me? Right? It's supplied by what artery, guys? Come on. What artery? Tell.
Posterior
interventricular artery.
Yeah.
Posterior.
Right? Yeah. Posterior interventricular artery, which is the part of what artery? Right coronary artery.
Right coronary.
What is the other point about the right coronary artery? What is the other point
It
about the
supplies
right
the
coronary artery?
AVN and the AVN.
We said right coronary artery is the one which is supplying the conduction system. So when you have an inferior MI, the next problem is they can develop heart blocks. They can develop what? Heart blocks. Right? So there is a patient with an inferior MI. There is a patient with an inferior MI. There is a patient with an inferior MI. After 1 hour, his heart rate, the monitor is showing heart rate is, right? Heart rate is 40. Heart rate is 40. Like heart rate is 40. Heart rate is 50. Right? Heart rate is 40. Heart rate is 50. Right? A good person should pick up. Oh, yeah. Right? Is he developing? Right? Is he developing a heart block? Understood? Right? Is he developing a heart block? You got it? Clear, guys? Right? Otherwise, these poor patients will die. That's a very important thing to have a, what do you say, proper knowledge. Yeah? So without this also, you can pass the exam. Right? You can pass the 45 for passing. Can pass the exam. But can pass the MD also. Can become a consultant. But you will be a general physician in a periphery. Right? Giving Paradol and right diclofenac. Right? You can never come up in the ladder. Right? Like there are thousands of general physicians every year. No? Can we just say I say that periphery and right do this nonsense and stay? Right? Understood? So got it? Is the message is clear? Right? Right. Okay. Look here. Right. So those are two things. It can also extend to the posterior surface of the heart. It can also extend to the posterior surface to the right. It can also extend to the posterior surface of the heart. Now I'll come back to this. Namai, how do you know there is a posterior MR? How do you know there is a posterior MR? Look at this point. Right. Yeah, I discussed this point in the theory as well. Like I discussed this point in the theory as well. Normally in the ECG, we don't put posterior leads, no. We don't put posterior leads. In a normally, like if you look at the V1, like if you look at the V1, normally in a normal person, V1 has a small R-way. V1 has a small R-way, but a deep paceway. It's like this. Like V1 has a small R-way, but a deep paceway. We'll discuss in the ECG class why this is happening like this. V1 has a small R-way, but a deep paceway. Small R-way and deep paceway. If you develop a posterior MR, right, what will happen to the V1? Right, V1 will have a tall R-way with ST depression. Right, tall R-way with a ST depression. This is what you get in the V1, V2. This is what you get in the V1, V2. There's a tall R-way with a ST depression. So if I say, remember guys, look here guys, look at me. Just think this is the ECG paper. Like just think this is the ECG paper. This is the ECG paper. It's going like this. Eh? So if you look at the V1, now it will be like this. V1, V2 will be like this. Okay. So when you see this in the ECG paper, right? When you see this in the ECG paper like this, V1, V2, what you do is you turn to the other side. You turn to the other side. When you turn to the other side, it looked like STEMI. It looked like STEMI. Understood? Like I'll show you here. Right? So look at these V1, V2. You're having a tall R-way with ST depression. Right? Now, what is the lead you will ask now to confirm? What lead you will ask to confirm?
Posterior lead.
P789.
Okay, very good, excellent. What are posterior leads you are going to ask?
789.
P789.
V789, excellent. V789. Understood? Yeah. So
Excuse me, sir.
spot? Right. Yeah. How to spot posterior infarction? Lama, look at me. As the posterior myocardium is not directly visualized, as the posterior myocardium is not directly visualized by the standard ECG, we have to look for the reciprocal changes in anteroseptal leads, that is V1 to V2. That is what V1 to V2. What are the reciprocal changes? Look here, horizontal ST depression, right? horizontal ST depression. Right, horizontal ST depression. Horizontal ST depression. Tall R wave, upright T wave. Right, tall R wave, upright T wave. And dominant R wave. Dominant R wave. So normally R wave is small. Here I'll say tall R wave, ST depression. Right, look at the T wave. It is upright. Right. In a normal ECG, like look here. Look at the R wave here. Look at the, now you understand. Look at the R wave here in V1. It's a small R wave, isn't it? Look at the R wave here in a normal ECG. It's a small R wave with a deep S wave. It is not dominant, no. Like in a normal ECG, if you look here. If you look at the V1 in a normal ECG, it is a small R wave with a deep S wave. Small R wave with a deep S wave. The R wave is not dominant. R wave is small. It is a dominant S wave. But look at the R wave here. When you develop a posterior infarction, look at the R wave here. Right? R wave is what? Tall. Understood? Come on. Are you there? Right? Got it right? Right, listen. Right, so that's how you pick up. Oh, my kids here. Look here. Right? This is the posterior AMI. Look here. This is the posterior AMI. Right? Right, tall R wave with a ST depression. Understood? Right? So why this patient develop a posterior AMI? Is he having an inferior AMI also? Is he having an inferior STEMI also? Huh?
Yes.
Huh? Yes or no?
Yes.
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 Yes. Look at the lead 2. Lead 2. Clear? Lead 2. Right? Okay. Look at the lead 2. Look at lead 3, mildly elevated. Look at the AVF. Elevate. So this patient inferior MI with a posterior extension. Clear? Right. Now, where are we? Sorry. Now coming to our patient. Now the background is clear now. What is hearing? Ken? What is hearing? What is hearing? I told all these things to interpret this ECG. Right? Yeah. You can use the axis deviation also. Right? What is it? What is hearing? What is happening in the V5, V6? ST elevation.
ST elevation.
What about lead 2, lead 3 AVF?
Inferior lateral.
ST elevation. Lead 2, lead 3 AVF, ST elevation. V5, V6, ST elevation. Lead 1 AVL, ST elevation. Right? So lead 2, look at me. Lead 2, lead 3 AVF, ST elevation. What is that?
Inferior.
Lead 2, lead 3 AVL, ST elevation. What is that? Inferior STEMI. Lead 1 AVL, V5, V6, ST elevation. What is that?
Lateral.
Lateral STEMI. So what is he having?
Inferior
It is a
lateral.
Lateral.
Inferior lateral
STEMI.
Inferior lateral STEMI. Understood? Yes or no? Lead 2, 3 AVL, ST elevation, inferior STEMI. V5, V6, lead 1 AVL also ST elevation, lateral STEMI. So if you combine all together, what is he having? Inferior lateral STEMI. The question I asked in the last night class. Last night long case mock session, I asked this question. No. Now what are you going to do? Come on, what are you going to do? What is your next step? What do you do? Answer.
Arrange for
So
a
since this patient didn't present after
Yes,
2 hours,
the best thing is what? In a STEMI, like this is theory, guys. You have to come to theory class or regular class. Like, what is the best thing for STEMI? You have to put a STEMI.
Primary PCI.
Primary PCI. Like, the best thing for STEMI is what? Primary PCI. So you will contact the cardiology team. Right? You will contact the cardiology team to do a primary PCI. you will contact the cardiology team to do a primary PCI. The primary PCI is not available. Right? Primary PCI is what? Not available. Not available. So what is the next thing?
Thrombolysis.
Thrombolysis. What is the next thing? Thrombolysis. Like we study, yeah, the kids don't worry. Thrombolysis. So what is the thrombolysis we are giving is tenective place. Right? What is the thrombolysis we are giving is what? Tenective place, tenective place, tenective place, tenective place, tenective place. So you may remember the Viva class. Before giving tenective place, we are giving IV enoxaparin, IV enoxaparin, right? IV enoxaparin. Clear? Then depends on the weight, your tenective place dose changes, right? Depends on the weight, your tenective place dose changes. If it is less than 60 kilogram, 30 milligram, 60, this is not my purpose of this today's class, this is Viva class, right? 60 to 70 milligram, 35 milligram, 70 to 80 milligram, 40 milligram, like that, right? Your tenective place dose depends on the body weight of the patient. So how to give tenective place? You give enoxaparin, 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 right? Then you give tenective place, tenective place, tenective place. Understood? Right, understood. I'll come back to this. Right. So after giving tenective place, right, you will start the subcutaneous enoxaparin. Right, after giving tenective place, you will start the subcutaneous enoxaparin. Clear? Right. What are the indications for thrombolysis? Come on, guys. What are indications for thrombolysis?
ST elevation MI.
Patient should come within 12 minutes.
Patient should come within how many hours?
12 hours.
Patient should come within 12 hours. What is the second point?
ST elevation MI.
Either there is a ST elevation MI or
True posterior
LBBB, left
LBB.
bundle.
true posterior MI or
new
left
onset.
bundle
New
branch
onset.
block. Left bundle branch block. Right? Either there is a ST elevation MI, true posterior MI, or left bundle branch block in the ECG. Left bundle branch block in the ECG. And the next point is, patient should not have the contraindication, isn't it? Patient should not have the contraindications. Right? Contraindication. Like we discussed in the emergency class, don't worry. Right? Patient should not have the contraindication. Why we are worried about our thrombolysis? Why we are worried? Why we are giving thrombolysis? To lyse the clot. To lyse the clot. To lyse the clot. What is our worry?
Can cause bleeding elsewhere.
It can cause bleeding.
Narration scope.
It can cause bleeding. It can cause bleeding. That's a risk. So you have to see whether the benefits is more than the risk. Whether the benefits is more than the risk. If you are anybody who are not attending the theory class, don't worry too much. I will discuss this a lot in the theory and Viva. Right? So you can't just understand like this. Right? You should not. Right? Look here. So in NHSL, when we are doing this, we'll inform the patient. These are the benefit, these are the risk. These are the benefit, these are the risk. Look at this, just for your knowledge. Right? This is the consent form. This is the consent form in the NHSL, just for your knowledge. Right? I authorize the doctors of the emergency treatment unit of the National Hospital of Sri Lanka to carry out the following treatment of IV tenective place or streptokinase, which are thrombolysis for acute ST elevation MI. Benefits of the procedure in most patients, right? Malfunction of the heart get corrected, but may not achieve 100% correction, right? It's not 100%, no. So you tell the patient, right? Your clot might be dissolved, but may not be 100%. Risk and complication. I understand any treatment can be associated with a complication that include allergic reaction, bleeding, adverse effect of the drugs, loss of body function, and failure to relieve the symptoms. Treatment can fail. The doctor has informed me that the particular risk, right, and complication associated with the drug, right, it can be even life-threatening including intracranial hemorrhage leading to death, right? There are some unforeseen conditions also which you are not expecting. I have read and understood the entire document. Understood? Right? This is a sheet we are using in NHS, right? To tell the patient, this is what we are using in the National Hospital. Understood? I just want you to show this, guys. I just want you to show these, at least to know these things are existing. Right? Understood? Kids, are you there with me? Yes or no? Right? So how to give tentative place? That is not the purpose of this today's class. Right? That we study in the Viva class. Look here. Now look here. How will you assess the response to treatment? Come on, guys, answer. When you give thrombolysis, how will you assess the response to treatment? Whether the thrombolysis is successful or not.
Pain reduces.
And
You come one by one. One is relief of pain. One is what? Relief of pain. So you will ask the patient, okay, how do you feel now? Right? Okay, how do you feel now? Right? The patient will say, doctor, my pain is better. Doctor, my pain is better. Right? Now I'm okay. Relief of pain. What is the second point, guys?
Hemodynamic stability.
Patient will become hemodynamically stable. Patient will become what? Hemodynamically stable. Hemodynamically stable. What do you mean by the word hemodynamically stable? Pulse rate, blood pressure will be normal or will come towards normal. Right? Pulse rate, blood pressure will come towards normal. What are you? Right? So pulse rate, blood pressure will become normal. Pulse rate, blood pressure will become normal. Clear? Third thing, guys. Third things. Look here. The ST segment is elevated, no? ST segment is elevated, no, in STEMI. This will come down, right? This will come down by at least 50%, right? This ST segment which is elevated, right? This ST segment which is elevated will come down by at least 50%, right? After 90 minutes, right? ST segment which is elevated, say it has gone by 4 squares, right? It is elevated by 4 squares. It will come down by at least 2 squares, right? By 50% after 90 minutes. In other words, you have to repeat the ECG after 90 minutes. Understood? Right? You have to repeat the ECG after 90 minutes. Understood? Right. So if this is successful, right? Right? That means what? Your thrombolysis is what? Successful. Yeah, your thrombolysis is successful. Actually, guys, even if it is successful, you can do a PCI, right? Even if it is successful, you can do a PCI and put a stent. Even if it is successful, right? Even if it is successful, you can do a PCI and put a stent. Even if it is successful, you can do a PCI and put a stent. Right? Thrombolysis is drug. So drug is called what? Don't write. We will discuss the class. Drug is called what? Pharmacology. So doing an angiogram and putting a stent is what treatment? Doing an angiogram and putting a stent is what treatment? Invasive. So this is called pharmaco-invasive therapy. What is PCI, guys? That is your stent there, primary coronary, right, intervention. You do an angiogram and put a stent or something, yeah? Right? Okay, percutaneous coronary intervention. You heard, no, they will do an angiogram and put a DINC, the small kids, right? So you put a DINC. I have shown some images earlier, right? You put a DINC, right? So if there is a block, you will put a stent. Like small kids, don't go here. Right, that is called percutaneous, because you go where the skin of percutaneous coronary intervention. Percutaneous coronary intervention. Percutaneous coronary intervention. Right, don't worry guys, kids, you'll study. Right, so if it is successful, still you can do a PCI. That is called pharmaco-invasive, invasive. Even if it is failed, then again you have to do a PCI. Right, if the thrombolysis fails, again you have to do a PCI. Right, that is called what? How do you call it,
Rescue
PCI?
PCR.
Rescue
Rescue.
PCI. You call that test rescue PCI. People be studying the theory and Viva, don't know yet. Those who are not attended yet, smart people. Clear? Right. Okay. Now look here. Right. These are the drugs we are continuing later. Like if the patient responds, these are the drugs we are continuing. We are giving subcutaneous enoxaparin, 60 milligram. BD means twice a day. We'll give it for at least 5 days. Right? Aspirin 75 milligram nocte, clopidogrel 75 milligram nocte, right? Atorvastatin 40 milligram nocte, ISM, nocte means night, nocte means night. ISMN, that is your night weight, 30 milligram mane means morning. Right? Enlapril and carvedilol. These are the drugs we'll give later. Right? You don't worry about this too much. Like this. Viva people should worry other one. Now look here, guys. Right? So, our patient. I'll come to our patient. Our patient chest pain persisted. Right? We have given tenactive place to our patient, no? Right? We have given tenactive place to our patient. Yes or no? Right? We have given tenactive place to our patient. Right? We have given tenactive place to our patient. Yes or no? Lama idea with me. Right? Okay, right?
Yes,
Right?
sir.
Yes,
Okay,
sir.
fine, yeah. Because I had to go for a party actually. Those buggers are calling me again. I said I will be there at 9:15. Right, look here. Our patient chest pain persisted. Right, we are given tenactive place. Our patient chest pain persisted. So what is your worry?
This is a failed
What is your worry? Whether the thrombolysis has failed. Whether the thrombolysis has failed. Yes or no? Right now we are repeating the ECG. Now I look here. Look at the repeat ECG. What do you see in the repeat ECG? Look at the repeat ECG. It's a weird scenario, guys. Like I went to the water and took photo by photo for your class. Look at the repeat ECG. Look here. What do you see here in the ECG? Look at the lead 2. ST segment is what? Still elevated, isn't it? Look at the lead 2, ST segment is still elevated. Look at the lead 1, ST segment is still elevated. Right? Okay. Look at the AVL, AVF, ST segment is still elevated. So there is no decrease by 50%. Right? There is no decrease by what? 50%. There is no decrease by 50%. There is no decrease by 50%. So this is what thrombolysis? This is what thrombolysis? This is a failed thrombolysis. This is a what thrombolysis?
Failed.
Failed thrombolysis. You are given the drug, but it did not work. Right? You are given the drug, now it has not worked. It has not worked. Now you can't do anything, no. Now you can't do anything. Right? There's no other way. You take the patient to the PCI. Right? You have to do an angiogram and put a stent. Nothing else can be done. Right? What are you going to do now? You're going to take the patient and put the stent. You call that as rescue PCI. Right? Rescue what? PCI. Right? You call that is what? Rescue PCI. Yeah, after 90 minutes. I did the ECG after 90 minutes. After 90 minutes, yes. After 90 minutes. rescue tissue. Now look at it. What is the MI this patient has developed? What MI my patient had?
Inferior lateral.
Inferior. Tell guys, I can hear you.
Inferolateral.
Lateral MI.
Inferior lateral MI. Right, inferior lateral MI. Now we will see the story. The story continues. Right, story is failed, no? Right, our PCI, our thrombolysis says fail. Right, okay, look here. Now, next day, right, look at the blood pressure 90 by 50. Look at the pulse rate 40. Look at the blood pressure 90 by 50. Look at the pulse rate 40. Right, 40. What does it develop?
Heart block.
Heart block. What does he develop? Heart block. But do you expect him to have a heart block? Do you expect him to have a heart block?
Yes,
Yes. Why did you expect him to have a heart block?
because he has an inferior involvement.
Because it's an inferior MI. Because it is an inferior MI. Because it is an inferior MI. Because it is an inferior MI. Understood? Right? Inferior MI can cause heart block. Now, look at me. What heart block is this? Anybody? I will teach in the ECG class. Don't worry. What heart block is this?
First degree.
Degree heart block.
First degree heart block. Any other answers? Huh? Huh? What heart block is this? Huh? Well, I come back to this. Look here. Right, we study in the ECG class. There's a full-blown ECG class in the Viva part 2. Look here. This is what R wave, isn't it? This is what R wave. This is what R wave. This is what R wave. Okay? R wave. What is the heart rate? Anybody tell me what is the heart rate? Anybody tell me what is the heart rate? I have not told you how to calculate the heart rate. I will teach in the ECG class. Anybody can tell me what is the heart rate? How to calculate the heart rate is, look at
Around 25.
This is the R wave. This is an R wave. Yes or no? This is an R wave. This is an R wave. Right, look here. Right. This is an R wave. Right. This is an R wave. Right. This is other R wave. So how do you call these intervals? Between two R waves, how do you call this interval?
RR interval.
RR interval. Right, between the interval between two R waves is what? RR interval. Now look here. How many large squares are there between these RR interval? Count. 1,
8.
2, 3, 4, 5, 6, 7, and if I count this and this, 8. Do you all accept that? There are 8 squares, isn't it? 1, 2, 3, 4, 5, 6, 7 is almost 8, isn't it? Right? Almost what? 8 squares. So how to calculate the heart rate is, like, I will teach you the ECG class. Don't worry. Like, how to calculate the heart rate is 300 divided by RR interval in large squares. RR interval in large squares. 300 divided by what? RR interval in large squares. 300 divided by RR interval in large squares. 300 divided by RR interval in large squares. Clear? Right? In large squares. Right? 300 divided by what? 8 is what?
8.
Somewhere.
Like
300
40.
divided by 8 is what? 37.5 or 38, isn't it? It's about roughly 38. So do you accept that point? The heart rate is somewhere around what? Come on, guys, answer, please. Heart rate is somewhere around what?
40,
38.
38.
Now look here. I will teach in the Viva class later. Right, okay. The session 2 of the Viva, this is there. Lamai, I'll tell you one point. This is the QRS. This is the QRS. This is the QRS. All the QRS are occurring at regular interval or not?
Yes.
All the QRS
Yes.
are occurring at regular interval or not? Huh?
Regular.
Regular interval. Regular interval. Regular interval. Now look here. This is a P wave. 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 Right? This is a P wave. 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 All the P waves are occurring at regular interval or not? Huh?
Regular.
Right? All the QRS are occurring at regular interval or not? Answer to my question.
Regular.
Regular interval. All the P waves are occurring at regular interval or not?
Regular.
Yes,
Regular
regular.
interval. Right? All the P waves are occurring at regular interval. All the QRS are occurring at regular interval. But is there a connection between the P and QRS? But is there a connection between the P and QRS? No,
No.
right?
No.
Right? No. Right? Right? P is coming separately. QRS is coming separately. Right? Your P waves are coming separately. Your P waves are coming separately. Right? Your QRS is coming separately. Right? Am I right? Your P waves are coming separately. Right? QRS is coming separately. It's like this, guys. Right? Normally, listen to me. Like normally, in a normal heart, this is how it goes, no? Right? Your P wave will be followed by what? QRS, isn't it? P wave will be followed by QRS. P wave will be followed by QRS, isn't it? That's how normal heart goes, no? So what is happening here? P waves are happening at regular interval, right? P waves are happening at regular interval. Your QRS is happening at regular interval, right? Your QRS is happening at regular interval. P waves are happening at regular interval. There is no connection between the, come on, P and QRS. P and QRS. This is what we call, as we'll study later in the ECG class, complete heart block.
QRS.
Right, this is what we call a third degree heart block or complete heart block.
Third degree.
Yes, third degree heart block or complete heart block. Look here. This is a complete heart block. Your atrial rate is around 85. Right? Ventricular rate is around 38. Ventricular rate is around 38. Clear? Ventricular rate is around 38. So none of the atrial impulse is going to the ventricle. Your ventricle is right, what do you say, discharge. Make sure the cameras are on net. Don't irritate. Right? Okay. Right. Okay. Right. Okay. Ventricle is right. What do you say? Discharging at regular interval, but there is no connection between the right atrium and ventricle. Right. No connection between the atrium and ventricle. Understood? Clear? Right. So this is what you call as complete heart block. Understood, guys? I just show you one more ECG here. Right. Right. Look here. So P waves are coming at regular interval. Right, your P waves are coming at regular interval. Right, your QRS is coming at regular interval. There's no connection between the P and QRS. That's what you call as complete heart block. Understood? Right? We'll discuss a lot in the ECG class, guys. Right, a lot in the ECG class. There are Viva session 2. I will discuss tomorrow in the Viva class. Right? It includes the ECG class and the emergency. It's all together. Right? Right, all together. Like session 2. Right, I will tell you tomorrow in the Viva class. Look here. So the last part of the class, right? Last part of the class, right? We'll finish the last part of the class with the ECG puzzle, right? We'll finish the last part of the class with the ECG puzzle. Clear? Right? Now look here. So the topic for the puzzle is right. So those days I put a big effort to write this question, right? Look here. VT or not VT, right? right? VT or not VT, right? What is VT? What is VT?
Tachycardia.
Ventricular tachycardia. Ventricular tachycardia. Ventricular tachycardia. What is VT? Ventricular tachycardia. Right? Okay. Ventricular tachycardia. The kids, you just listen and just listen for their interest. Right? VT or not VT. Right? So, right. Okay. And I put a great effort to write these guys. Right? Even after about 20 years, if somebody is going through this lecture, they should have understood. Right? Right. What an effort has been put on that time. Right? This is the scenario. Right? Right. Okay. Right, look at the scenario, guys. Right, I just made the English names to make it nice, right, rhyming. Right, the first day of your internship, right, in the middle of the night, right, a strange-looking patient is brought to the ward. Right, okay. Right, okay. His name is William. He can be a Radnayaka or somebody, but doesn't matter. We'll make it William for the sake of interest, right? His name is William. But he says, call me Bill, right? But he says, call me Bill, okay? Strangely, his last name is Shakespeare. This is your first day of the internship, right? Okay, you know William Shakespeare? Right? Yes, no? Right? Okay, so you giggle, right? Okay, like the first day, no, you're already afraid. Right? What a funny name, you think so familiar, right? Like the day one, so the nurses also will try to harass you on day one because they know you are new, right? Right, you are new, right? So they want to show their colors, right? So what is happening here? This patient has been brought, right? So his name is William Shakespeare, right? He's asking you to call him as Bill, right? Okay, right. Now the pretty nurse, right? She's poking his ECG to you, right? She's poking his ECG to you, right? Okay. Right, okay, look here, now we come to ECG, right? This is the ECG, right? I'll discuss it again in the Viva class, but anybody, right? What is ECG?
VT.
VT. Right, we'll answer, we'll see. Yeah, all saying is VT. Yeah, sure, right? Huh? VT or not VT? Huh? I can hear you. Talking something else. Right? What's the diagnosis? Dawson, tell me. Right? Whoever got a very good mark for medicine, tell me. What is the diagnosis? VT. Okay, we'll see. Right? Okay. We'll move on to a scenario. Okay. So this is the first day, no, guys. So you are seeming pretty smart, right? Because you have just finished your Viva, right? Viva exam, right? So you are somewhat confident, no? But you are shivering inside, right? Okay. So you ask this nurse, right? Is this an ECG I see before me? Right? Come, let me touch D. What is D, guys? Come on.
ECG.
What is D? Oh, you are all studied from MMB.
You.
Yeah, D is you, eh? In Shakespeare's language, D is you. Like literature, in Shakespeare's language, D is you, right? So let me touch D, right? That's all the Shakespeare will say, right? Let me touch you, right? I feel you not, yet I see you still, right? This fellow is now panicking, right? The nurse still bewildered about your comments on touching the ECG, and she's wondering about your madness, right? Now, nurse is trying to interpret the ECG, right? Okay. So the nurse is telling this ECG is completely abnormal, right? So you are panicking with the ECG, but now the nurse is telling you this ECG is completely abnormal. So now you also realize, no, okay, there's a problem, right? So you are trying to, what you say, calm her down. You are trying to humor her. You are saying, yeah, you say, you are correct, right? You are correct. The patient is having a white complex tachycardia, right? White complex tachycardia. So what is tachycardia, by the way? Heart rate
Heart
is
rate
more than
100.
100. Right? What is tachycardia? Heart rate is more than 100. When will you tell white complex? What is the normal QRS? What is the normal QRS? The normal QRS is less
160.
than the width. The normal QRS is less than, right? Normal QRS is less than, right? 3 small squares. The normal QRS is less than how many small squares? 3 small squares. The normal QRS is less than 3 small squares. 1 small square is how many seconds? Right? 1 small square is how many seconds?
0.04 seconds.
4 seconds. 0.04 seconds. So the normal QRS is less than 0.12 second. Right? Normal QRS is less than 0.12 second. That is less than 120 millisecond. 120 millisecond. 120 millisecond. Clear? So this patient is having what? Right? Look at the QRS. How many small squares, guys? Look here. It's about 4 or 5, right? Right? Right. It's about 4 or 5, right? Okay, this is more than 3 now, guys. This is more than 3, am I right? Yeah. So it's wide complex. Right? What is the heart rate now? It's about, right? Our interval is somewhere around 1 square, right? It's about 300, isn't it? It's about 300. Right? Okay. So, right, you try to humor her, you are saying, you are correct. The patient has a wide complex tachycardia. Right? But is this VT? Right? But is this VT? Clear? Now our Bill, right? If you turn to our Bill, because Bill is there in the bed, right? He is gasping. He's barely conscious, right? The Bill is barely conscious and he's asking you, right? He looks at you and says, VT or not VT? That is a question. Clear? VT or not VT? That is a question. That is how Bill is telling you. Now coming to that point. Clear? Now, this is the ECG. This is the ECG. So, this will make more sense after ECG class. So, what is the definition of wide complex tachycardia? Am I right? What is the definition of wide complex tachycardia? So, wide complex tachycardia, as the name says, QRS complex needs to be wide. Right? QRS complex needs to be wide. Understood? What is wide? What is wide? That is more than 120 millisecond. That is more than what? 120 millisecond. Clear? So that is more than 3 small squares. That is more than 3 small squares. Understood? That is wide complex. Second point. Second point. Clear? The patient needs to be tachycardic. The patient needs to be what? Tachycardic. Patient needs to be tachycardic. Right? Patient needs to be tachycardic. Okay. Now, what are the differential diagnoses of a wide complex tachycardia? Obviously, one is ventricular tachycardia. Obviously, one is what? Ventricular tachycardia. Other one is, guys, look at me. If you have the small kids right there, this is for your aunties and uncles, right? Right. Other one is SVT. What is SVT?
Ventricular
Supraventricular tachycardia with bundle branch block. SVT with what? Bundle branch block. You may be aware, we have studied what? Left bundle branch block, isn't it? Left bundle branch block. Left bundle branch block, how the QRS will look like? Villia. Right? Villia. In the word William, come on, look at me. In the word William, there is double in the center. In the word William, there is double in the center. So remember that L for L. L for L. L for L. Right? Left bundle branch. your V1, your V1, your V1, your QRS is white, it looks like W. Your QRS is white, it looks like W. In the lead V1, your white QRS will look like W. In the lead V6, your QRS will look like M. In the lead V6, the QRS will look like M. The seniors, I have studied, told you, right? I told you in the theory, I told you in the Viva. Right? Okay. How to remember right bundle branch block?
Marrow.
Marrow. Marrow. In the word marrow, there is double R in the center. Remember R for R. Remember R for R. R for R. Right? So V1, right? Your QRC look like M shape. V1, QRC look like M shape, M shape, M shape, M shape. V6, right? Your QRC look like what? Sorry, W shape. V6, never know. QRC look like W shape. Right? So your bundle branch block already have what? White QRS. So on top of that, if they develop an SVT, right? Okay. So again, it will be a white complex tachycardia. What is SVT? We studying the ECG class, proper ECG class. Today I have done only the introduction to ECG, guys. Don't teach everything here in a free class. Look here. Now, next point. Clinically, guys, clinically, what clinical features differentiate VT from SVT? VT from SVT, right? If the patient has, right? If the patient has, right? If the patient has, right? Okay, right? If the patient has no prior history of tachycardia, right? Or if they have a structural heart disease, if the patient is on a pacemaker, or if the patient is on a cardiac defibrillator, VT is more likely, right? VT is more likely, right? A patient with a heart disease, pacemaker, structural heart disease, ICD, VT is more likely. In the examination, if the patient is unstable, what I mean by the word unstable, blood pressure is low. Blood pressure is low. If the patient has heart failure, if the patient is having a midline sternotomy scar, if the patient have an ICD, canon wave, right? Heart sound is fluctuating. Again, VT is more likely. Clear? In the ECG, right? VT is the common one. SVT with a bundle branch block, VT is common. Right? Okay. If there is an extreme axis deviation, what is axis we'll study, don't worry. Right? VT is more likely. If the heart rate is sharp 150, SVT is more likely. I'll come back to this point again, don't worry. Now, come and look here. Features of VT, ventricular tachycardia. Point number 1, they are having very broad complex tachycardia, guys. They are having very broad complex tachycardia. Very broad complex, right? Right? Say it can be even larger than 160 milliseconds. It can be even larger than what? 160 milliseconds. Second point. I told you, what is the other differential diagnosis for the broad complex tachycardia? Come on.
SVT.
SVT with a answer.
Bundle
Bundle
branch.
branch block. SVT with a bundle branch block. Right? So SVT with a bundle branch block, this pattern is there, no? This William, W pattern, M pattern, that is there, no? That is there. So if that is not there, absence of the right bundle branch or left bundle branch pattern. Absence of what? Right bundle branch or left bundle branch pattern. Absence of right bundle branch or left bundle branch pattern. Clear? Extreme axis deviation. I'll come back to this right in the proper class. Then there is something called AV dissociation. There is no relation between the P and QRS. P and QRS. There are two words, guys. Just remember the words for MCQ. There are two things we are seeing in the ventricular tachycardia. One is capture beats. One is capture beats. One is capture beat. What is capture beat is? What is capture beat is? Lamai, look here. Lamai, look here. What is this beat, guys? What is this beat? What is this beat? What is this beat? What is this beat? Tell. These are VT, no? These are VT. These are ventricular tachycardia beats. So in between the VT beat, suddenly a normal beat is there. All these are what beat? VT beat. All these are what beat? VT beat. VT beat. VT beat. So in between the VT beat, suddenly a normal beat is there. Suddenly a normal beat is there. That is called what beat? Tell guys, please. That is called what beat?
Capture
I can hear
beat.
you. Answer, please.
Capture beat.
Capture beat. Capture beat. Capture beat. Sometimes, guys, look here. Sometimes, like this VT beat and normal beat, can join and produce a new wave. This is called fusion beat. Look here. These are VT beats. These are VT beats. These are normal beats. These are normal beats. So if you look here and here, this VT beat and normal beat, they have joined together and they are producing a new beat that is called fusion beat. Understood? So tell me the two features I told you now for VT, please. Tell me the two features.
Capture beat and fusion beat.
Capture beat, fusion beat. Capture beat, fusion beat. Like in a great depth, I will discuss in the ECG class, but this is like this is a combined class now. Like theory, ECG, everything together, mixture. Right? The last point, guys, last point. Positive or negative concordance throughout the chest leads. Throughout the chest leads. Now I look here. What is meant by that is, now I look here. In a normal person, like in a normal person, if you look at the V1 has a small R wave, deep S wave. V1 has a small R wave, deep S wave. So when you go from V1 to V6, your R wave will become progressively large, S wave will become small. Like in a normal person, V1 will have a small R wave, deep S wave, deep S wave, deep S wave. By the time you go to V6, chest lead, V6, your R wave will become large, S wave will become small. S wave will become what? Small. Like somewhere in V3, your V1 and so your R and S will be equal. Somewhere in V3, R and S will be equal. So V1 have a small R wave, V6 have a large R wave. So V1 is mainly negative, V6 is what? Mainly? Come on, guys, please. V6 is mainly positive. This is what you get in a normal ECG. So look here. What about here? Right? All are negative, no? What about here? All are negative, isn't it? Right? All are negative. So you don't see the transition, right? You don't see the transition. The negative to positive transition. You don't see the transition, right? Here, look here, guys. So you don't see the transition here, right? You don't see the transition here. Right? You don't see the transition here. Yeah? The negative. Do you understand what I am talking? Huh? Do you? Yes or no, guys?
Yes, sir.
Yeah? So you don't see the transition here. Right? You don't see the transition here. Right? You don't see the transition here. Right? Okay. Say, so Lamai, if you look at the normal ECG, Lamai, look here, this V1 is mainly negative, no? Like this V1 is what? Mainly negative, yes or no? This V1 is mainly negative. V1 is mainly negative. Say, this is mainly negative. Say, so look at the V6. V6 is mainly what? Come on, guys, please. Positive. Isn't it? V1 is negative, V6 is positive. So we see that in a normal ECG. We'll see that in a normal ECG. Like, but here we don't see. Here we don't see. We don't see that here. Like, we don't see that here. Understood? Right, look at this. The last thing to finish off. Right. Now, you ask the nurse to connect the patient to the cardiac monitor. Like our William Shakespeare, he asked us to call him as Bill, right? You ask the patient to, you ask the nurse to connect the patient to the cardiac monitor. Look at the blood pressure, 70/40. Look at the blood pressure now, what? 70/40. That leads to the famous SBA question, single best answer in the exam. Adult tachycardia, patient unstable. What will you do?
Easy shock.
Adult tachycardia, patient unstable. What will you do?
Shock.
Shock. Right? Adult tachycardia, patient unstable. What will you do? Shock. That is theory knowledge. Adult tachycardia, patient unstable, you will shock. Is he stable? Is he stable or unstable?
Unstable.
Unstable. This patient is unstable. He's telling VT. Right? Look at the blood pressure. Patient is unstable. Right? You don't know what to do. Right? You don't know what to do. You don't remember adult tachycardia, patient unstable, shock. Right? Even though we have said several times in the class, at that tension, right? You are unable to remember, right? Adult tachycardia, patient unstable, shock. You look at the patient, right? You look at the patient, right? Bill is now looking at you and he's right whispering, right? He's about to go, right? He's whispering, a shock, right? My kingdom for a shock. Clear, right? So what am I supposed to do now? Right? Shock, right? So that's what about, right? Integrated word class. Clear, right? That's what about what? Integrated word class. Understood? I hope you gained something, right? I put a lot of effort on this, right? Right? Okay, right? I hope you gained something. Let me know the feedback, whether it's useful or not. If you like, depends on that feedback, I will see how many short classes to do on this manner. See you guys, but I also have to leave then. Good night, bye. The next class is tomorrow, right? 12:30. Bye.
Good night.